Okay, let's start then. It's time to kick off the meeting. So, hi everyone, welcome to today's meeting with Oncoplastic Academy from Brazil. Good morning, good afternoon, and good evening wherever you are. So I can see many friends of us from all over the world, and welcome to you all. So today, we will be talking about different aspects of oncoplastic surgery, and we have 6 distinctive guest faculty, 3 from Brazil and 3 from Turkey. All are the breast surgeons except one. Professor Nuran Beshe is a radiation oncologist. Always we welcome her to contribute to our discussions among the surgeons. And let's talk about Oncoplastic Academy, because every time we try to host a society or an institution to our meetings. So these 3 oncoplastic surgeons from Brazil are the founders of Oncoplastic Academy from Brazil, and we are very much privileged to host them today. So they are also organizing many courses, hands-on courses, cadaver courses. Also, they make meetings on breast surgery up to now in Brazil and also abroad, many countries all over the world. So today I will be co-chairing Hagis Hezenci Paulinelli. Dr. Paulinelli currently works at the Program of Mastology, Department of Gynecology and Obstetrics at Federal University of Goiás in Goiânia. And also he works at the Gynecology and Breast Unit at Araújo Jorge Hospital. I don't know if my pronunciations are correct. I'll try to exercise on that. It's very difficult for me to talk in Portuguese. And well, Hagis, most of you know all these 3 gentlemen from Brazil. And Hagis does research in plastic surgery, radiology, and breast oncology, apart from his main breast therapeutic surgery area. So he's also the vice president of the Oncoplastic Committee of the Brazilian Society of Mastology. And our second guest from Brazil is Cicero Arban. He is a professor of surgical oncology and working as breast surgeon and hospital Nossa Senhora das Graças at breast units. I think that's also, I don't think that was a bad pronunciation. And also head of Oncoplastic and Reconstructive Surgery Division at Centro de Doenças de Mama in Curitiba, Brazil. And he's also a very well-known author and editor of 6 different books on breast surgery, including oncoplastic breast surgery. And his fields of interest are beyond oncoplastic and reconstructive breast surgery, also clinical bioethics and medical education. And finally, from Brazil, Maurício Hezenci is a breast surgeon and faculty member at Federal University of Sergipe and its University Hospital at Aracaju in Brazil. He's an experienced faculty as well in oncoplastic breast reconstruction in his country and abroad. He is also the head of traditional hands-on course in oncoplastic surgery and breast reconstruction in João, Brazil. So also we have 3 more guests. I introduced one of them in the beginning, Professor Nuran Beshe. She's a professor of radiation oncology in Acıbadem University School of Medicine. And also we have 2 guests from Senatürk faculty, Professor Hasan Karanlık from Istanbul University Oncology Institute, and Dr. Cem Yılmaz from European Academy of Senology and Senatürk working in Istanbul Oncology Hospital. So today, before I will be giving the microphone to Hagis, I would like to give very brief instructions about this meeting. Here we will have 5 presentations. At the end of the presentation, we will take your questions, but you can write your questions on the chat box. We will be collecting those questions to forward them to each of the speakers according to their presentations. And also we will have a tumor board in between, and during that approximately 50 to 55 minutes of the mini tumor board. And there will be also discussions on 3 different cases presented by Hasan Karanlık. And at the end of that tumor board, also we will receive your questions from the chat box and forward them to the discussants at the end of the tumor board session. So your videos will be open if you wish, but your voices will be muted and you cannot unmute yourself. But if you really want to say something, you can write in the chat box, and maybe we can open your voice and microphone, and you can ask your question by yourself or comment by yourself. Okay, so with this, I would like to give the microphone to Hedges, and he will also make a small, a brief introduction on themselves as well. Okay, Hedges, the microphone is yours.
Thank you very much. It's really a pleasure to be here with you. Uh, uh, I think Dr. Bahadir have already did a very good job on introducing ourselves. We believe that oncoplastic surgery and breast reconstruction are integral parts of good breast cancer treatment. In addition to preserving or even improving self-esteem in some cases, it may increase the indications for breast conservation in difficult cases, reduce re-excision rates, and help achieve free margins. It's very important that breast surgeons and plastic surgeons learn it properly and incorporate it into their practices. Senatürk is already well known for its scientific and educational activities in Turkey and around the world. Oncoplastic Academy is a new educational initiative of a group of Brazilian friends, breast surgeons, dedicated to breast cancer treatment and breast reconstruction. Over the last year, we have organized individually or together many congresses, hands-on courses, cadaver labs, research, scientific papers, book chapters, books. We have traveled around the globe. It's truly an honor to help Senatürk organize this webinar today. We hope you enjoy this first joint efforts. Hopefully there will be many others. we can move forward. I'd like to introduce Dr. Mauricio Resende. He's a professor of the Federal University of Sergipe. He organized, as well as I do, one of the well-known hands-on courses on oncoplastic surgery in Brazil on behalf of the Brazilian Society of Mastology. Please, Mauricio.
Hi everyone, good morning for Brazil and good afternoon for everywhere. It's a very pleasure to be here with you. I'd like to start. Can you share my screen, Nata?
I think you can share your screen, Mauricio. Can you try it again?
I'll try it. Good. Yeah. Can you see me?
Let's see. Not yet.
That's it?
Yes. Yeah. Now I think it's now we can see it.
Let's minimize.
Yeah, you may go on, Mauricio.
Let's start. Let's work. Senatürk asked me to talk something, and it's joint venture between us, Oncoplastic Academy, me, Regis, and Cicero. We are very, very happy to be here with you today. It's Turkey is a very wonderful country. I have been there about 40 years ago, and to stay here with you makes me feel good sensations always. Oh, I cannot. That's it. Me. This is Regis. He lives in the central west from Brazil. Cicero, that lives in south, and me, that live in northeast. This is our county, and be everywhere. Everybody invited to know us and to know our country. I have no conflict of interest to this presentation, and Bahadi asked me to say about easy case scenarios. But what does it mean, Bahadi? Let's go to the dictionary. What means easy? Easy. A lot of things means easy, but I have 2 points that I call irritation. Free of trouble, anxiety, pain, etc. Like an easy life. Good, very good. That we have here in Brazil. Uncomplicated, good. Conclusion? I don't know what means easy, but as a surgeon, use easy probably means fast, probably means basic knowledge, little possibility of complication. There is no complication, of course. Anyone is able to follow and repeat the steps, and little scars. And I choose 3 cases to try understand what means easy, if there is easy in surgery, and to show you what's easy in my point of view. In this scenario, I prepared 3 cases. 1, easy. This is completely easy. The second one, most of them are easy. And the third one is made it easy. We can do it too, of course. The case 1 is you using just local flaps. Then you have small displacement, replacement with local or local regional tissue. It's the first step in oncoplastic surgeries, and we have normally little scars. Present you 39 years old, perioral invasive cancer, histological and nuclear grade 2, triple negative after neoadjuvant chemotherapy, and size at the end with 2.1. Negative axilla, and she loves the shape and size of the breast. Then she says, the right breast is bigger and little ptotic compared to left. I prefer symmetrics, that's it. But I love my breasts. Perfect. This is the lady. What she has a tumor, 2.1 centimeters, and a little bit difference between the breast, where the right one is a little bit bigger. We can see a difference between the lines of the upper level of the areola. We have a difference. And she asked, is it possible to correct and let this breast a little bit smaller? Okay, let's try. This is an easy case. This is a very easy, in my opinion. It cannot answer what means easy at the dictionary, but I can do it. Small scars, little pain, small trauma, and small complication, of course. Then you have a half moon of depithelialized skin. We access to the tumor. We perform a second incision to treat the axilla. And we have a wide field to work here with tumor margins. If we need to make shaving, of course, we can do anything. And after, we can move the tissue, neighbor tissue, let's call it this way, to fill in the hole that created into the breast. And you have this final aspect. Of course, we have here some edema. And at the end, we have this breast that, compared with the first one before the surgery, we have 2 very, very symmetric breasts. And attending her, what about her expectations? She like to have a breast, or the breasts, just similar as they were before the surgery. I think this is an easy case. This is of probably little complications, little scar, little pain. I think this is an easy case, of course. I could do more things, more scars. I have put a vertical scar. I could take the breast out. I could have performed an oncoplastic technique, but sometimes the little is the enough. This is the surgery that we performed in this lady. We will prepare the the operative field. The first step is to mark the areola incision. Then we have different cases, different areola size, different necessities. We have all the breasts that are free from the skin. You can see my finger. All my finger can run into the breast. Then I'm free to take out the tissue with the margin that is necessary. I'm taking out the tissue, and after just close the glandular flaps that we perform into the breast. This is an easy case too. In this case, we performed 2 different incisions too. One in the axilla that she had to perform axilla complete dissection, and another in the areola. Be careful with the suture that you must perform Benelli suture using an non-absorbable wire. I have a third case, but I like first, Ata, if possible, to make a question to the audience. Is it possible to do this right now?
Okay.
I'd like to ask you guys this question. In cases of breast cancer in patient with previous aesthetic implant surgery, must we keep the implant and treat the cancer, change the implant and treat the cancer, explant and treat the cancer, mastectomy is preferred, abstain, no idea? I'd like to give you 30 seconds, it's okay?
Anyone can answer the questions here. If you have no idea, you can put the mark on no idea as well.
Ata, I'd like that we have the answers before the presentation of the third case, please.
Okay.
Not now, you mean, Mauricio?
Okay.
Okay.
Do you have the case? Do you have the answers?
The answers, yeah. But can you put the answers on the screen? Yeah.
Keep the implant and treat the cancer, 55%, okay. Change the implant and treat the cancer. And explant and treat the cancer, perfect. Mastectomy is preferred, okay. I'd like to show you a case that probably, of course, in oncoplastic surgery, we have a lot of ways to treat a patient. And I'd like to show you a case that I think it's very interesting to think about the treatment every time we have one case like this. 47 years old, screening mammogram, was detected a tumor, a non-palpable tumor, size 1.8 at mammogram, and 1.1 at ultrasound. Right breast, upper outer quadrant. At core biopsy, invasive ductal carcinoma, histological grade 2 and nuclear grade 3. No comorbidities. Proud of her breasts. I like very much my breast. I had before a little breasts, and now I have breasts because I have the implants. Previous aesthetic additive surgery about 8 years old. 8 years before, sorry. But another problem, she desires a little bit bigger breasts. Her words, when I made the surgery, I have bigger breasts. They were perfect. But after 8 years, so I think I lost something of my breasts. Then we have 4 problems to solve, to answer here. There's a non-palpable tumor, There's an implant added with 255 ml, a bigger breast at the end she desires, and aesthetic is very important for her. This is the mammogram, where we have a tumor that is located in upper outer quadrant and deep, far from skin, close to the implant, but not at the capsule, for example. We have a distance between the tumor and the implants. No palpable. When you see her, we think this is a very difficult case. We have problems to solve here. And I'd like to show you, let's try make this case easy. She's the lady, here's the tumor, 1.8 at the mammogram, and this is her breasts. Okay, let's start operating her, making her surgery. This is during, oh, I'm sorry, the sound. The tumor here, and we make an incision, we go down, and after we go through the implants. We perform it. We went down to the chest wall, and after we make a curve and go looking for the implants. We are taking out the implants. We're cutting the capsule. Take out the capsule. Sorry, take up the implant, explantation. This way, take out. Until now, I can't feel the tumor. I didn't mark her. I didn't use hook. I didn't use technetium, anything. This one is the second step. Let's take out all the capsule. Using fingers, I love this. I think iron is hard. We can hurt the breast tissue. Then I prefer every time I can using just my fingers. Continuing. Until now, I don't know where's the tumor. But with the explantation, I can feel with my finger, because the mammogram showed me where is it and as close it is it from the capsule. This is the end. Sorry about the sound. This is the end of the capsule. The capsule is out. I'll check if it's completely took it off. It's okay. And now I feel the tumor and take out the tumor by direct vision and by direct sensitive with my finger. In this case, I preferred to use another incision to sentinel lymph node, this one. And this is the final aspect of the surgery. Now I put the implant. We wash with just saline solution. A lot of times. Sorry, guys. And I'm implanting another implant, a new and bigger one implant. And I close the wound with 3 plans. One plan deeper plan with non-absorbable wire like nylon to close the part that is deeper. Another one intermediate, and another two on the skin. We have the different layers of tissue to close. This is a safer way to work this way, in this kind of patients. This is the final aspect. This is the final aspect from the surgery. We cannot see scars. This is before, this is after. We changed the implant. Now she has an 350, and of course, no cancer no more. I think this is too an easy case too. Ata, can you make the same question again to the audience?
Okay.
Let's try answer here right now too. 30 seconds more too. Of course, we can do everything we want. And who answered anyway, it's right too. Anything can be performed. I disagree, just mastectomy is preferred. No, mastectomy can be done too. Can you see the answer? Oh, good. The audience changed it. This is not the single way to treat, but we can see here someone we had before 55, now we have 38. It's perfect. It could be done this way, yeah, of course, but not by that incision. We should perform another incision over the tumor, and probably we will create another scar. But it's right too. It's perfect. Can you close the answer? Okay, this is my little daughter. I'd like to present you. She's Maite, and appreciated to be here with you. It was a very, very big pleasure to be here. Thank you for all.
Okay, thank you very much, Mauricio. That was a very good presentation for easy cases, and your description was interesting, and I think everyone can accept those descriptions as well. Well, you know, it depends on the surgeon's experience, whether the case is an easy or a difficult one, and you're an experienced surgeon, so that was good to hear from you those examples as well. Okay, there are a few questions. Maybe I can ask you one or two of them before we pass to the second speaker, who is Hedges, because these are interesting questions. The first one is coming from Dr. Borg from Malta and UK. She's asking how this would have been managed if there were positive margins. She's asking to you, Mauricio.
I normally perform freeze study during the surgery. Then if I have positive after, not in the frozen section, I will make the same surgery probably. I'll be back to the surgery, take out the implant to make another plan to try free margins. I normally only perform mastectomy after margins with tumor, not before the second try.
Okay, so Dr. Andriy from Ukraine is also asking about the margins. Do you color them and do frozen section?
Yeah.
Okay, and also one comment from Dr. Ahmet Dağ from Turkey, and also the same comment came from Professor Valerius from Lithuania. They're asking, why don't you use roll technique or wide-guided surgery for the non-palpable breast cancer?
Because I was sure in this case that I could find it easily. That's it. But normally, if we don't have this case in normally a case a non-palpable tumor, of course we must use. I normally use technetium. But I showed you in this case, just in this case.
Okay. Let's go to the next speaker because there are very good questions. I will just keep those questions and ask you just after all the talks are over. But now, because we have to keep on time, so now I would like to invite Hedges to the microphone, and he will be this time talk about worst case scenarios. Hedges, the microphone is yours.
Okay, thank you. I'll try to share my screen. Congratulations, Mauricio, for the presentation. It's up to me to talk about worst cases scenarios in oncoplastic surgery. How to increase the indications of breast conservation in locally advanced breast cancer, small breast, multicentric tumors. There are some cases that are very difficult. I would like to ask Ata to make my question, please.
Okay, I'm launching it.
Do you consider it safe to perform breast conservation in locally advanced breast cancer? Please answer. Can we see the results, please? Oh, that's good news. 73% of you believe it's safe to do breast conservation in locally advanced breast cancer. It's very good because at the beginning I was very questioned. I was questioned many times about the safety of our procedures. Well, I published I have recently published a systematic review of the literature on the conservative surgical treatment of locally advanced breast cancer. It's in English. I invite you to read it. There is much scientific evidence of its safety. Unfortunately, there aren't randomized trials, but there are many level 3 and some level 2 pieces of evidence. Just to name a few papers, in this analysis of nearly 40,000 patients of tumors larger than 5 centimeters from the National Cancer Database in the United States, 1/10 of the patients received conservative treatment, and the 10-year overall survival was the same as in the mastectomy group. This other research suggests that the size of the tumor and positivity of the lymph nodes may be more important than limited skin involvement. This large European study with more than 6,000 breast cancer patients with multifocal or multicentric disease treated with neoadjuvant chemotherapy showed that breast conservation had similarly outcomes to the mastectomy. And why is so important to try conservative treatment in such difficult cases? Wouldn't it be better or easier to perform a mastectomy? We are creating a database of our patients that have completed all stages of breast reconstruction and returned to our office after at least 6 months of surgery or radiotherapy. In this partial analysis of 567 patients, partial breast reconstruction, that is Oncoplasty, led to much better satisfaction using the breast Q, much fewer complications. The rate of complication was more than double for mastectomy. And the number of surgeries, like in this case, like here, the number of surgeries performed are much bigger for patients with mastectomy. Everybody can show beautiful results at conferences, but nobody wants to show complications and bad results. Capsular contracture after radiotherapy, skin necrosis, infection, loss of implants, and that's a reality. Unfortunately, for breast conservation, for breast mastectomy, much more than breast conservation. Much more research support the same conclusions. It's much better to do a partial than a total breast reconstruction whenever possible. Dr. Silverstein from the United States popularized the term extreme oncoplasty, after publishing 76 cases of breast conservation associated with mammoplasty, with the same rates of local recurrence and excision as in case of smaller tumors. There was, although, a slighter increased risk of closer margin and conversion to mastectomy. Dr. Benigno Nebril from Spain recently published further 33 cases, and Dr. Richard Ransbury from the UK 90 cases with similar results. And after seeing this, I decided to revise our database, that database that we are building. We found 102 patients with tumors bigger than 5 centimeters, and it was possible to do a conservative treatment in 32.4% of the cases. We had the same excision rates, but a slighter higher risk of conversion to mastectomy compared to tumors smaller than 5 centimeters. The rate of local recurrence were 4% in 5 years and 14% of 10 years, the same as in the literature, in the mean follow-up of 66 months. Interestingly, we could do extreme oncoplasty. Oh, sorry. Interestingly, we could do extreme oncoplasty in the double of case of what we've seen in other series, 33% versus 10 to 18%. Why was it possible? For oncoplastic surgery, it's much more used. When I was learning oncoplastic surgery, my masters taught me that by knowing these 3 techniques, we could solve more than 90% of the cases. Superior pedicle for tumors in the lower quadrants, and inferior pedicle for tumors in the upper quadrants, a round block for breast with limited pitosis. For other circumstances, a mastectomy would be needed. But there are many other techniques, volume displacement techniques, volume replacement techniques. And when I looking back at my data, if I had only known mammoplasty, I would have doubled the case of mastectomy in such big tumors. Contralateral immediate mammoplasty was important for the success, and in some cases I had to use a personal type of mastectomy called geometric compensation, which I will comment on. It was also important to dominate more types of areolar pedicles than the conventional inferior or superior pedicles. And it's possible to increase the rates of breast conservation. Mammoplasties have some limitations. For example, when the tumor compromises important landmarks of the mammoplasty, like the medial or lateral pillars, or when it's far from the usual resection areas, especially when it's too close or involving the skin. I sometimes use a technique called plug flap, described by Dr. Dyer, a Brazilian plastic surgeon. It works well in some locations, but may be risky when it creates parallel scars that can impair the vascularization, and we can have some necrosis. So, thinking about it, to solve this kind of problem, I thought of this modified mammoplasty, which we spare the lower triangle, usually resecting the Weiss pattern and transpose it to the tumor area. This patient, for example, had a 6.5 tumor in the upper medial quadrant of the right breast with thickening of the nipple and skin, with no response to the neoadjuvant chemotherapy. Instead of excising the lower triangle, we excised a geometrically equivalent area over the tumor. In the end, we had this Z-type, Z-shaped scar instead of an inverted T. But the symmetry was very good 6 months after chemotherapy. We published for the first time this technique in 2014 at the Journal of Surgical Oncology. We published 17 cases like this. This year we have published 73 cases, including some variations and evolutions of the technique. It was the back cover of the journal. I invite you to read it. And here, for example, some modifications like moving the A point to the other side of the scar to avoid retraction. Just a minute. Again. Oh. Okay. Now I can put the video. I think this video will help you understand geometric compensation. It was a 42 years old patient with an invasive ductal carcinoma, grade 3, triple negative to the right breast, with 13 centimeters palpable lump and skin retraction in the upper medial quadrant. Bloody nipple discharge without response to neoadjuvant chemotherapy. It was a T3 and N1. Mammograms showed an extensive area of microcalcifications within the palpable area. It's a very tough case. I believe many of you would perform mastectomy. Here the preoperative marking. The A point is the projection of my finger on the inframammary fold. It corresponds to the new position of the nipple. Here checking for the symmetry, here the tumor area. We mark an inferior referential line about 10 centimeters from the midline. And the other side. And in recent years, I tend to mark the nipple 1 centimeter more, the referential line 1 centimeter more, and the nipple 2 centimeter more to the opposite side of the tumor, because of the scar retraction. Here the Bisenberger maneuver, estimating the sagging skin. We gently push the breast up and to the sides. Then the horizontal line, 10 centimeters from the A point and 6 centimeters to the edge of the areola. Here I measure the lower triangle and transfer it to the tumor site. The logic is very simple. We just move the site of excision geometrically over the tumor. The contralateral symmetrization will follow the classic Weiss pattern, with a supermedial pedicle in this case. But it could be any pedicle as needed. Here the markings, the final markings. And here you can see the quadrantectomy specimen. Here it's very huge. It weighed at 261 grams. It's like a mastectomy for many patients. We marked the margins for pathological evaluation. In this case, we kept the volume of the lower lateral quadrant because otherwise the breast would be too small. We just open it. We use the same incision for axillary clearance. We just ductilize it, so we are ready for closing. First the vertical pillars, then the defect. It's important to close both gland and the skin to prevent sinks. we always use metal clips for boost orientation. Dr. Beza could comment on it. In this case, it was possible to immediately reconstruct the nipple complex. For this, we deepitalized the recipient site and harvested part of the contralateral nipple and areola as a free grafting. Here, the areola marker, we deepitalize it. How we do the nipple sharing. We took part of the nipple, part of the areola, we harvested it. And here the free grafting and compressive dressing after. It's important. Yes, here the immediate aspect, the brown dressing, and here 1 month after surgery. You see that can be possible to do a conservative treatment in such difficult cases. In the last 4 or 5 years, we have been trying to avoid scarring over the tumor when there is a free superficial margin. In some cases it's not possible, but in some cases yes. We couldn't let the skin too thin and devascularized, but we had the idea of keeping it attached to the lower quadrant to preserve the volume and blood supply. As in the geometric compensation, we move all the corresponding area. Here how it works. The thin skin over the pillar kept attached to the lower quadrant. It's very easy to close it without tension. We take all of the tumor like geometric compensation, all the triangle over the tumor, but without the skin, and the skin is kept vascularized by the inferior pedicle. So far we have 17 cases of this technique. It's a new technique, fortunately hassle-free, no complication, no necrosis, no dehiscence. All results are good or excellent by the Harris scale. Sure, there will be complications in the future when we have more cases, but it seems to be very safe. We don't have the time to show a video of this technique here, but you may find it and much more. There are more than 80 other educational videos on my personal website. Here's the address. You can take a picture. You can also scan the QR code if you prefer. And I invite you to know the Oncoplastic Academy. We are very pleased to be here with you. Thank you, Dr. Bahadir, Dr. Hassan, and everybody from Senatürk. Thank you very much.
Thank you so much. Hey, just as was always, you're giving a nice presentations as an overview for all these cases, which are mostly difficult to regular breast surgeons, but you're making these much more simple for us. Okay, so there's one comment for you from, let me see, from Professor Valerius, again from Lithuania. He's asking whether is it possible for this case to do omegomammoplasty with intraoperative examination of the retroareolar tissue, preserving areola, and to do a separate incision on the axilla. Would it be possible to do it as a simple way?
Well, maybe, but I don't think it would correct the ptosis the same way. I don't think the results, the symmetry would be so good as in this case of the geometric compensation.
Okay, let me see if there's any more questions. Maybe I may go back to one question to Mauricio. Is Mauricio with us? Ata, can you unmute Mauricio, because there are very good questions for Mauricio.
Yeah.
If I can, yes, all right, okay. These are questions just coming privately to me, so you cannot read this. But most of the questions are answered by Mauricio on the chat box, because they were related with using radiation treatment to those patients that Mauricio showed us. And he gave the questions to the audience, but there are a few questions. One of them is from Professor Mahmut Müslümanov from Istanbul. His concern was about the final symmetry, because he says that according to his experience, that 5 years later, following to the radiation therapy, there is some proportion of shrinkage, which you cannot imagine or predict exactly just 5 years prior to that effect. So should we leave little big breasts for this reason? Do you think that is that necessary, Mauricio?
I don't think so. I thought that before, when you perform a bilateral surgery and one side needs to perform radiotherapy, I thought the best. Let the breast, the sick breasts, for example, the tumor is on the right side, and let's leave the right side a little bit bigger, because after radiotherapy they have an atrophy and got smaller. That's one way to think, but I think nowadays this is a wrong way to think, because we must perform the surgery, and the surgery must be good at the time the surgery, after the surgery, and after this, what comes is chemotherapy, is radiotherapy. And if it happens some difference, it comes from radiotherapy, not from surgery. When we leave the breast bigger today, I did a bad job, because I didn't do symmetric positions, sizes, forms. And after 5 years, we have different, because it's very, very difficult. And the radiotherapy is a process of atrophy. It doesn't go atrophying and stops. No, it's continuous, evolving during all their life. Then I think if we leave them today symmetric, they will be symmetric. And radiotherapy, or if she got fatter, she got thinner, it moves, but not by my fault. But when we try to perform a different breasts, waiting a result from radiotherapy that we cannot know how often, how hard it will be, I think we take to us the fault, the guilt.
Okay. One final question. Probably you answered partially to this question. This is from Mr. Konstantinos Zakariodakis from UK, from Manchester area. He asked you 2 questions, but I think you answered one of them. But just be more precise on this question. I would like to ask you again. In the case where the implant doesn't, the position of the tumor, well, it says a little bit complicated question. Let me rephrase it. Doesn't the position of the tumor affect your decision to perform a capsulectomy? For example, upper inner quadrant. Doesn't opening the capsule and changing the implant increase infection rate?
I think, of course, how more things we perform, more risks of infection. Of course, if tumorectomy has less infection, less pain, less bleeding, then quadrantectomy, then mastectomy, of course. But I think when we need to open a breast, when we have an implant with 8 years, I think we perform, especially in this case, it's different when we have a mastectomy and we have a complication from the tumor. We cannot do a capsulectomy, and sometimes we perform just capsulotomy. But in this case, I think it's easy. There is no, I show it you. Don't believe me. You believe what you're watching in the movie. It's very, very, very easy. I think, Buddy, I think I answered some question here at the chat. Can Can you
Yeah,
see?
yeah.
Oh, good.
Yeah,
good,
yeah,
good.
we can see. Yeah, that's why I'm not asking every question to you, because the audience can follow your answers to those particular questions, because there were questions from our Turkish colleagues and also from our Bangladesh colleagues from the Bangladesh. So
Perfect,
you
perfect.
answered them very, precisely. So I'm not asking those questions again. All right.
Sure.
Oh,
Thank you.
let's go move on to our next speaker. Now it's Cem Yılmaz's turn. He will be talking about modified techniques in oncoplastics. The microphone is yours, Cem.
Thank you. Thank you very much. First of all, I wish all my colleagues a good day. And I would like to express my gratitude to my colleagues in Brazil for their kind invitation, and my dear colleagues, Dr. Hasan Karanlık, Bahadır Güllüoğlu, and Sertaç Atagüler, for this beautiful organization. Today I'll try to give you detailed information about the practices of our clinic of modified techniques in oncoplastic surgery, and how we interpret international expertise within our framework. Well, in Istanbul Oncology Hospital and in Senatürk, what do we understand from oncoplastic breast surgery? Oncoplastic breast surgery is the name of our general techniques that allows immediate breast reshaping, wider excisions, and better cosmesis. And what are our criteria we care as we are deciding the operation type? Is the patient preference, tumor location, the breast cup size, possible effects of irradiation, and duration of the operation and the anesthesia risk. And what are the common techniques that we perform in Istanbul Oncology Hospital? These techniques were developed and modified in Düsseldorf by Dr. Mahdi Rezai, and he trained in Düsseldorf 37 Turkish breast surgeons in European Academy of Senatürk. And with this support, intraoperative ultrasound, modern oncoplastic techniques disseminated in Turkey and surrounding countries. These common techniques that we generally use, of course, these are not, one size fits all, one technique fits all techniques, but the first and the most common one is the glandular rotation, dermoglandular rotation, reduction techniques, lateral advancement flaps, thoracoepigastric flap, latissimus dorsi flap, and for the reconstruction techniques, implant and the others, and the other techniques also. For the central located retroalar tumors, for the cup A and cup B breast, we perform glandular rotation flaps. When in cup A and B breast, when we need a nipple excision, we perform Grisotti. And in type C and cup C and beyond, we perform reduction mammoplasty techniques. And in Istanbul Oncology Hospital Breast Center, which is affiliated to European Academy of Senology, today we are challenging ourselves in oncoplastic procedures. We also follow the quadrant per quadrant atlas for oncoplastic surgery, which was published by Krishna Kloff and his friends in 2010 also. And for the upper outer quadrant tumors, when we have a cup A and B breast, we perform glandular rotation flaps. When we have a cup A and B breast, we need a skin excision, we perform lateral advancement flap. And when we have cup C and beyond the breast, we perform reduction techniques. The first technique, the glandular rotation technique, that is suitable for 65% of all breast cancer cases. The operation times, the duration depends on the patient's the tumor size. It varies from 5 to 15 minutes, and it's suitable for all types of breast. But when we have cup C and D breast, we consider breast reduction in order to prevent radiation toxicity. But when reduction is not feasible and there's a risk of anesthesia, glandular rotation is a relatively feasible operation. And in cup A patients, we consider tumor size relative to the breast size, and we always keep in mind that the neoadjuvant treatment is another option. The first tip and trick, we always mark the tumor site under preoperative ultrasound as the patient is in the operation position. And we always mark the incision as the patient is standing up. And we always mark the sternal notch to areolar border and mid-sternal line, as if we don't use them. And We always use intraoperative ultrasound. We take care of skin thickness. The fat tissue must not be thinner than 5 or 7 millimeters, and we do not overcoagulate the subcutaneous fatty tissue. We respect the subcutaneous blood supply, and we do not over dissect the breast. And our motto is dissect as you need. And the incision on the breast tissue and the skin must cross each other. We will need that cross effect as a roof support during the irradiation, so that it will prevent the dimpling effect of irradiation after the first 6 months of irradiation. And when we have a tumor in the lower outer quadrant, in cup A and B, the breast, glandular rotation flaps, cup A and B breast, when we need a skin excision, we perform dermoglandular rotation flaps, and cup C and beyond, we perform reduction techniques. What is dermoglandular rotation flaps? That is suitable for 7% of all breast cancer cases. It's suitable for cup A, B, C, and D, but in cup A, patients consider tumor size relative to the breast. Also, of course, again, we keep in mind that neoadjuvant treatment is another option. And when cup C and D breasts, we always consider breast reduction in order to prevent radiation toxicity. But when it's not feasible, dermoglandular rotation is a fast surgical choice, and the operation duration is between 5 to 10 minutes. This technique is suitable for tumors which are located between 3 and 6 o'clock regions. The technique depends on skin and tumor bed resection like a piece of cake. Of course, you can perform it in 6 o'clock region. And let's have a look at the drawing. We always use preoperative ultrasound to see the margins of the tumor. And in this tumor, you see the dimpling, you see the skin retraction. So we need the resection of the tumor bed and the skin. And we will mobilize the skin and glandular flap from medial and the lateral portions. Both you can use the flaps from lateral or medial or both. And the inframammary fold in order to prevent the irradiation, because irradiation's effect of retraction, skin retraction, the keyhole deformity, we will perform a 2 or 5 millimeters of desepitalization below the inframammary fold, and we will put the new inframammary fold on new desepitalized region. So you can, as you see, we dissect both glandula and the breast together. And as I mentioned before, you can bring both medial and lateral portions of the breast tissue. And it's a very fast and easy operation, as we mentioned, as Bahadur Güloğlu mentioned, in the easy techniques. And there's another technique that we call for the upper outer quadrant tumors, lateral thoracic advancement flap, that is suitable for 3 or 4% of cases. It's suitable for upper outer and lower outer quadrant cases, and suitable for multifocal and multicentric disease also. And suitable for all cup A, B, and C breast, and the operation duration is between 15 and 20 minutes. This technique is simply designed as a partial latissimus dorsi muscle mobilization by Dr. Mahdi Rezai in order to prevent using of latissimus dorsi, total mobilization of the muscle. So let's have a look at our case. We have a 42-year-old patient. You see the skin retraction on the upper outer quadrant. The tumor was luminal A tumor. The axilla was radiologically and clinically negative. And there were some microcalcifications and radial scar-like formations in the upper inner quadrant and the outer lower quadrant of the breast. The breast was cup C breast, and the patient asked for preserving the size of the breast. We are resecting the tumor. We performed the sentinel node biopsy. Unfortunately, it was positive. Now we're performing the axillary dissection. We love to use bipolar scissors as we are performing the axillary dissection. It's a very, easy tool, and it's cheaper than all those other, LigaSure and the others. And in the lateral thoracic advancement flap, it's for, enabling to use the few portion of the latissimus dorsi muscle. It enables the surgeon to reach upper inner and lower outer quadrants. And it's a level 2 technique, but this technique is simply relies on the resection of more than 40% of breast and reconstruction it with partial relocation of latissimus dorsi muscle without cutting and mobilizing it anteriorly and suturing it to the pectoralis major muscle. Here you see the serratus anterior muscle, and now we're dissecting the latissimus dorsi muscle from the skin. Here you see the latissimus dorsi. We bring latissimus dorsi as much we need. And the technique simply depends on suturing the pectoralis major muscle to the latissimus dorsi. And there's no need to mobilize the nipple areolar complex in this technique. 3 or 4 sutures is enough to fix the muscle connection. We put 2 drains in front and behind the muscle. It takes only 15 or 20 minutes in this patient. It took for resection and the reconstruction of the region. Here you see we located the incision on the anterior axillary line. And here is the post-operative second year. You see here the incision on the anterior axillary line. And there's no difference on the size of the breast, and there's no laterality of the new nipple areolar complex. And when we have an upper inner quadrant tumor, when we have the cup A and B breast, again, glandular rotation flaps. In cup A and B breast, when we need skin excision, we perform latissimus dorsi flap. And in cup C and beyond, we perform reduction techniques. And lower inner quadrant tumors, in cup A and B, again, glandular rotation flaps. And when we need skin excision, again, dermoglandular rotation flaps. And in cup C and beyond, we perform reduction techniques. And there's another modified technique from Dr. Mati Rezai. There are several limitations associated with the principles described in reduction mammoplasty. From the surgical point of view, there was a need for a unique and standardized technique for reduction mammoplasty, which can be implemented either in a tumor-adapted reduction strategy in breast-conserving treatment or in aesthetic surgery for reduction and mastopexy. Besides the volume reduction, several other aspects have to be considered when developing a unique reduction mammoplasty technique, combining prerequisites from breast conservation, treatment, and aesthetic surgery. This technique should have the following aims and the possibilities. So Dr. Mati Rezai and the team, worked on these aims. First, the creation of the desired breast size and the shape, breast symmetry, variation of width of the breast bases, optimization of the projection of nipple areolar complex, reconstruction of the upper breast pole, scar sparing procedure, avoidance of secondary ptosis, correction of lateral bulging, and combination with an oncoplastic procedure like segmental resection in breast cancer patients, and conversion to the skin sparing mastectomy with reconstruction in case of positive margins, result of good outer and inner aesthetics, the breast diagnostics during aftercare, and adaptation of the contralateral breast reconstruction after mastectomy. For the development of a unique technique in reduction mammoplasty, which fulfills these prerequisites, it's important to differentiate the 2 unrelated steps: the inner reduction, the volume reduction, and the outer reduction, the skin envelope reduction. Combined with the original technique of Ribeiro with an inferior pedicle, Rezai developed a modified inferior technique with a superior pedicle nipple-areolar complex and an inferior dermoglandular flap, which are the two important steps for the volume reduction. And let's talk about the case sample. This was a hard case. This patient was 30 years old, nullipar patient. She had a multicentric tumor, and unfortunately, she was operated with excisional biopsy, you see, from 6 o'clock region and 4 and 5 o'clock regions. And when we took care of the patient, we examined, we saw that she has microcalcifications and she had a HER2 positive luminal tumor. And in the tumor board, we discussed and decided to think as if she is a locally advanced tumor because the tumor size was T3, and we performed the neoadjuvant treatment. And after neoadjuvant treatment, we received only microcalcifications were present in the mammogram, and there was no sign of tumor in the post-neoadjuvant therapy mammogram and the MRI. And we decided to perform wire localization, and we performed Rezai technique mammoplasty. When you compare the two, you see the projection of the nipple-areolar complex, and the new location of the nipple-areolar complex is on nearly 21 or 22 centimeters from the sternal notch, and the patient was quite happy with the technique. And let's talk about a little bit more about the technique. Well, this, in this technique, we start from the drawing process. The drawing process of this technique is similar to non-mastopexy techniques, with the patient in the half sitting or standing position. Mid-clavicular line and the vertical line is drawn from the hemiclavicular line to the upper edge of the areola. And we always keep symmetric. Inframammary fold determining is very important. And what we do as a tip and trick for this technique, this is the inframammary fold, and this is the lowest point of the inframammary fold. When you draw a line between the two lowest points of the both breast inframammary fold, 4 centimeters up is the location, new location of the new nipple-areolar complex. That is the apex of the new nipple-areolar complex. And we check it via hand, finger, whether the location is right, with the new nipple-areolar complex location is right or not. And again, the most important technique, we have to prevent the pressure on the skin. We have to prevent the pressure. So we use our finger to see whether the breast is, breast skin is mobile and there's no tension. There won't be any tension on the new nipple-areolar complex and the vertical incision of the new breast. We draw it to 10 centimeters. Again, we check the tension, and the new position of the areola must stay away from the pressure. And as you see, we mark by means of the pinching, the maneuver, and the surgeon's judgment. The surgeon determines the lateral lines to 10 centimeters from the upper region, and we draw the lines. So the inferior fold, approximately 12 or 14 centimeters needed. And we don't directly use the strict line. We draw it like an arc in order to prevent the pressure on the inframammary fold. And you can use this technique not only for reduction mammoplasty techniques. It's quite safe to use in subcutaneous mastectomy implant reconstruction techniques also. How we use it? We use as you see here, the desepitalized skin as like an acellular dermal matrix, and we suture it to the pectoralis major muscle, and we reconstruct the breast easily with this new flap. As a conclusion, every clinic and surgeon have their own expertise and surgical guideline. In Istanbul Oncology Hospital, we chose the systematic of Dr. Mati Rezai. This systematized the techniques of EOS that fit well in our environment, and we also challenge our techniques according to our experiences. And obrigado, and thank you very much, and hope to see you in Istanbul also.
Okay, it's your turn. You can unmute yourself.
Okay.
Okay.
Congratulations, Dr. Jan Wilmas. I like the T-shirt.
Thank you. That is from 2006 World Cup.
It's very nice that you've been in Düsseldorf. I myself went there to be with Dr. Werner Aldrich many years ago. I didn't have the opportunity to know Dr. Madi Reza at that time. He wasn't anymore at the same hospital at Dr. Aldrich. But I've learned many of these techniques, and it's very useful. It's very interesting for you to put it here. There was a question in the chat from Dr. Andre. She's asking, do you really need to remove the skin above the tumor? In all cases, when you do it?
Well, when we have a luminal A tumor that the board and the medical oncologists think that it can be resistant to neoadjuvant treatment, yes, we remove the skin. But if the tumor is suitable for neoadjuvant treatment and we will have a good result after neoadjuvant treatment, we directly send the patient to neoadjuvant treatment. But in luminal A tumors, we all are afraid of the effects of the neoadjuvant treatment.
Even if it's far from the skin, it's used to remove it.
If there's excess skin, yes, of course. But if there's excess skin, so we have to prevent the pressure on the skin. The tension is the enemy of the oncoplastic surgery.
Okay. I'd like to introduce Dr. Cicero again. He will give another lecture. I think now it's Dr. Cicero or Dr.
Oh, that's right. Cicero is on the next line.
Yeah.
Right. Yeah, it's Cicero's turn.
Okay. I'd like to introduce again Dr. Cicero Urban. He made a specialization in oncologic surgery in Brazil and breast oncoplastic surgery in Italy. He's a good friend and international reference in oncoplastic surgery, reviewer of numerous journals, authored and co-authored hundreds of peer-reviewed papers, have many book chapters, some books. He will talk about complication. It's a very important part of our work. Please, Dr. Urban, your turn.
Thank you, Regis. After all these wonderful presentations about techniques and good results, it's up to me to present you the worst part of our job. I'm sorry. We have complications. So, just a minute. Avoiding and managing nightmares. This is my disclosure. I don't have conflict of interest in some advertisements. Some of these complications are not mine, but could be, all of them. And some of these cases could have more than one alternative to solve them. So the aim of my presentation here is to try to show you a way to organize our decision-making process in case of complications and to try to avoid them whenever it's possible, of course, because sometimes it's not possible to do it in our practice or to avoid it. And 3 practical secrets. Don't tell to other people outside here. What I am not going to be able to show here, that's important to make it clear. I will not be able to demonstrate how to resolve or prevent all complications in oncoplastic and reconstructive breast surgery, of course. But all of us had these feelings these regrets sometimes in our lives. If I could, I never had reconstructed this case. And this is something that happens in our practice. And I will try to show you how to deal with this difficult situation. We had how to unify three different situations in a model of logical and reproducible decision. Cancer characteristics, breast shape, and maybe the most difficult part of our job, patient's desire, patient's expectations. So just have the number 3 in your head. What are the most the errors, the 3 errors in surgery? We have failures, technical failures, judgment failures, relationship failures. All of them can damage the patient. But our most relevant failures in our practice are not the technical ones inside the theaters. The most relevant failures that we have in our practice came from misjudgment. And that's the way we should think in oncoplasty. Poor cosmetic litigation in the past was very rare in breast cancer patients. But litigation is rising up with patient expectations after breast conserving treatment using oncoplastic techniques. Unsatisfactory cosmetic outcome is now the second commonest reason for legal action against breast surgery. But the typical size of the claim, fortunately, is less than for delay in the diagnosis and less than aesthetic surgeries too. Number 3, like I told you, we have 3 different classes of patients, 3 different kinds of patients. Those with good and those with bad aesthetical outcomes, those satisfied and those unsatisfied with their outcomes, those with good relationship and those with bad relationship with their surgeons. And the worst combination for a claim, for example, is a bad outcome, a clear bad outcome, unsatisfaction, and bad relationship. And we have 3 different classes of corrections in our practice. Possible or impossible, because sometimes it's impossible to do a correction. Simple or complex, and evidence-based correction or not evidence-based correction. And the most common of them, the most common combination is a possible, complex, I mean more than one procedure to achieve the best result, and not evidence-based correction. It is experience-based correction. First secret here, oncoplastic surgery has complications. And unfortunately, this is part of our job, and this is not uncommon. We can have small and big disasters. A small disaster here, just the dehiscence of surgery, and a big disaster in this size, where we have an extrusion of the implant and the ADM together in an irradiated patient, and she's a doctor. So from small to big disasters, we should know how to deal with and to have skills to solve the complications and to prevent them. This is a publication in the New York Times saying that 1 in 5 patients requires more surgeries in breast reconstruction, and 5% of our reconstruction fails. So this is something very common in our practice. We know that we have some groups of patients which are risky patients, like smokers, obese patients, irradiated patients, bad quality of flaps, for example, in mastectomies, but even in quadrantectomies and oncoplastic techniques, in patients who underwent neoadjuvant chemotherapy. So, what is the worst aesthetical result among these 3 patients, according to you? Ata, please put the first question to the audience. Would you please?
Okay.
Well, patient 1, patient 2, patient 3, abstain. Oh, I have no idea. I think that we have an idea. So let's go to the answer, please. Of course, 97%. The number 3. This is the worst statistical result. Well, and what do you think? Which of these 3 patients is the most dissatisfied with their statistical result? 1, 2, or 3? Or no idea, because you didn't talk with the patient. But let's try to think whose patient is with greater dissatisfaction in this case. So let's go to the answer, please. Please share the answers. Number 3. Well, symmetry after oncoplastic surgery. Patient number 1, unfortunately and surprisingly, maybe to you, but not for us, because it is frequent in our practice that the worst is not the most dissatisfied patient. In patient 1, we have the high degree of dissatisfaction on the part of the patient. In patient number 3, we have the high degree of dissatisfaction on the part of the surgeon. And why this patient is so dissatisfied? Because of her bikini. You can see here that when she goes to the sea, when she goes and uses her bikini, part of her areola is out. And this is something very frequent in my country, in Brazil. As you know, it is a country where we have very nice place to go with a bikini. Where is the most complex correction? Of course, number 3. It is necessary to combine mammoplasty and lipofilling. And the others, just a contralateral mammoplasty, we can do a good correction. Second secret, and the most important, keep it in your minds. Lower patient expectation in oncoplastic surgery. Attention, this is not aesthetic surgery. Oncoplastic surgery is an oncologic surgery where we do a reconstruction and symmetrization. This is a study that we are, it's not ending at the end, but we apply the breast Q quiz to our patients in Brazil. And I was frightened with these preliminary results because all of our patients don't think that their breast will be different after oncoplastic surgery or a reconstruction after mastectomy. About 10% of them think that their breast will be equal after a consultation with us, with my team. This is before surgery. This is before surgery. Before everything we do, sending papers to the patient to read, folders to read, and to be prepared to the surgery. And they think that after 10 years after breast cancer surgery, they remain thinking that their breasts will be equals in conservative surgery with oncoplastics and in mastectomy. So this is frightening. And we know that patients evaluated their results differently from BCCT core, for example, from the specialists, and they think many times that their results are better than the specialists and the BCCT core. This is a good news. But of course, we have at least 10% of our patients, at least in Brazil, thinking that their breast will be perfect. And this is not good. Well, Litigation in breast surgery is most of times about tales and expectations. Expectations is patient's tales, education, surgeon's tales, and even in the courts. And we should think that virtually all patients with breast cancer are vulnerable, as all live with uncertainty of whether their breast cancer will recur and whether they may prematurely succumb of disease. So they are vulnerable all times. And maybe the secret for a good result, for a satisfaction of our patients, is to underpromise and overdeliver during our relationship with our patients. I'm not telling you to lie to the patients, but underpromise, I mean, this is not aesthetic surgery. This is a surgery that has many limitations, and you will undergo through radiotherapy in the future. So we have many reasons to revisional surgeries: contour problems, volume problems, nipple and areola asymmetry, problems with base dimensions, inframammary fold abnormalities, seam envelope, scars deformity, and so on. But the most important question is not what is the best conduct, but how to decide considering patients' values and evidence-based medicine. What did you do in this case, for example? 82-year-old patient, and she underwent immediate breast reconstruction with implant without symmetrization. Now she's with a capsular contracture and implant rupture. So, Ata, please put the question number 3 to the audience. Remove the implant and replace. Replace the implant and put an implant and contralateral for symmetry. Remove the implant, abstain. No idea. What do you think is the best situation for this patient from the clinical point of view and from the statistical point of view, of course? This is not an easy case. Seems an easy case, but it's not an easy case. So let's go to the answers. Well, replace the implant and put an implant in contralateral breast for symmetry. Remove the implant. Well, let's go. Just removing the implant and the patient is more symmetric than before. Remember, she has 82 years old, and for many of these patients, it's not a good way. It's not necessary to do a perfect breast, for example, to have a breast of 30 years old. The third secret, lower surgeon expectation. And remember, sometimes late corrections are complex in bad surgeries. For example, this case, how she underwent a quadrantectomy with a known, maybe not good technique for quadrantectomy in a small breast. And it's necessary many surgeries, sometimes 2 or 3 surgeries to correct something that in the beginning could be not necessary. In other times, it's impossible to do something like this case. Well, bilateral mastectomy and reconstruction of implants, asymmetry shape, volume and inframammary crease, capsular contractor, Baker 3. What we should do in this case? The answer is lipofilling, capsulotomy, ADM and implant, flap. Keep it simple. Always keep it simple. Capsulotomy and implant change. Very fast surgery, change the implant, and you have a good result. More complex case, implant extrusion, as you can see here. What you can do in this case, LD flap, then this is the result after all. Let's go to maybe the worst scenario. Young patient, 30 years old, invasive ductal carcinoma, 8 centimeters, no response to chemotherapy, and expander. Change the expander, radiotherapy, in the bubble sign and the disaster. What you're gonna do in this case? Just one answer, in a thin patient. LD, second, LD, and third, LD. Of course, the answer is LD flap. And after an LD flap, we had again a disaster, an extrusion of the implant. And again, what you're gonna do in this case? My suggestion, send to a friend. But I didn't have friends at that time in Brazil, 10 years ago. And what we're gonna do in this case, if you don't have a friend to send this case, a tram flap, bipedical tram flap, microsurgical flap, ADM and expander, and we did a tram flap. So this patient had 2 flaps to solve one disaster, one big disaster. Well, this is the final result, and maybe one of the worst scenario. It's necessary to think that quality of life depends directly on our decisions in surgery. And in conclusion, complications, unfortunately, are the most unpleasant part of our job, but how to solve them and how to prevent them should be included in the skills pocket. Time and experience, of course, reduce our skills, our risks, and better our competence and skills in prevent and solve them. Oncoplastic surgery, remember, is not aesthetic surgery. It is not an easy surgery, and this should be clear to our patients in the pre-op period. This is my acknowledgement to my team in Brazil, and thank you very much for this partnership, this wonderful partnership with Senatürk. I'm very proud to be here, very, very happy to share with you our experience in oncoplastic surgery.
Thank you so much, Cicero, for this beautiful talk. As always, it's inspiring, seeing all those, experience on your slides. Thank you so much for sharing all those with us. All right, there's no question for you up to now, as far as I see. Maybe to just buy time, maybe I may ask one question for Jem, because there was one question from the previous presentation, but we missed that question. Maybe meanwhile, somebody would ask a question for you as well. So Ata, can you unmute Jem? Okay,
yes,
Jem, there's a question from Dr. Tamer Fadi Youssef Yacoub from Al Ain, from United Arab Emirates. Maybe you remember him, he's a close friend of us from Egypt. Now he's working in United Arab Emirates, and he's asking a question: what is the satisfaction rate for dermoglandular flaps in comparison with upper or lower pedicle technique?
Well, it depends on the size of the breast. When you have a breast size of cup C, it will be a little bit dissatisfaction for the patient and the surgeon also, because the effect of the irradiation, all the strength against the gravity, forces the breast skin up, so that you have a small dimpling effect. But it's so fast surgery. It's oncoplastic surgery. After the operation, the patient is quite happy with the result, and the complication rate of the operation is low. But when you have a big breast, we have to stay away from this technique.
Okay, thank you. So any more questions for Dr. Urban? No, maybe I may ask a question for him. Ata, can you unmute Cicero? All right.
Yes.
Yeah, thank you again, Cicero, for your beautiful talk. I would like you to ask a question. You know that we are now using some tools to assess the outcomes of the oncoplasties. Do you use regularly a tool, or do you recommend any one of them? Do you think any superiorities or inferiorities of those different types of tools? You're an experienced surgeon and you're very busy with that. I'm sure that you're keeping your data very intact, and Good. So what would your advice to our surgeons listening to us?
You mean to static results in oncoplasty, or to, because we are using BreastQ in
Yeah.
research, with research purpose. We are using now a very nice software, Chrysalix, which is we can preview what will be the result of the surgery before, but it's something dangerous if you don't use it with giving very good advices to the patient, because you can up their expectations when when a patient, for example, can see their results with a reconstruction or with an oncoplastic surgery, and she can think that she will have a very nice result, and sometimes we have some situation that it's not so good as it is in the software. So we are studying it in breast reconstruction, and we hope to publish it in maybe in 1 year, because we are doing this. These are just preliminary results, and the part of these preliminary results are presented. I don't think that it's possible to have a nice preview, and we don't have until now, in my opinion, a complete tool to analyze well the results in breast reconstruction. I don't know what's your experience, but I don't think that we have a complete or a best tool to use in all the cases.
Well, my opinion is yes, we have to use one kind of a tool to assess the outcome, because it's also important, because you're doing it for aesthetic, outcome. Of a oncological outcome is important. Yes, we follow these patients, not just us, also radiation oncologists and medical oncologists as well. But the aim here is, of course, you're also concentrating on to, maintain the cosmesis of the breast. That's why we need to use some kind of a tool to assess our results, to audit ourselves. It's very important. Yeah. Otherwise, you're doing something, but you don't know what you're doing. And also here, your opinion is not that important, as you showed us. The patient's view is much more important than yours. Yes. That's why we need to use a very simple tool, but it should be there should be one tool to assess the outcome, so you can understand what you're doing right or wrong.
My advice, if I have just 1 minute to answer,
of course, please.
Way. Yes, my advice to you is do your pictures very well. I have, as you saw in my presentation, I put the patients in the same position and with a blue wall in the back. So I can see the difference, and I can show the patients the difference that they have, the asymmetry that they have before the surgery. And this works very well, because sometimes patients look, oh, look, doctor, my breasts are not equals. This is something different. My inframammary crease is not in the same. But if you show them that they had already some asymmetry, and that this is the normal, most of times it works. But of course, to analyze, to quantify the symmetry is our big challenge. We tried to develop in the past a software to do it, as we have, for example, with BCCT core. And until now, I don't have the best answer to this big challenge. But do good pictures before and after. Show the patient the result. I think that most of times they will be able to understand the outcome.
All right, you're right. There's no best method to assess the patients in aesthetic way, but you need to use one of the easiest ones, which you use. BreastQ is the one that we are also using in our daily practice. So I also recommend everyone to use mainly the BreastQ, but you can use anything else to this in addition to BreastQ, of course. But that's that's a necessity to use one of those tools minimum. All right. Okay. Thank you very much again, Cicero. Now I would like to move on to our final speaker, Professor Nurhan Beshe. And as I told you in the beginning of the meeting, she's a radiation oncologist, and she will be telling us the view from the radiation oncology side. Because, you know, we are doing this kind of oncoplasty mostly as a breast conserving surgery, and that's the must to add an radiation oncology or radiation treatment to this treatment. So we are not swimming alone in these deep oceans. So she will be letting us to know their concerns after what we do by means of oncoplastic surgery. Yeah, the microphone is yours, Professor Beshe. Thank you for coming and sharing your slides with us.
Thank you, Bahadur. It's always a great pleasure and honor for me to be a part of Senatürk organization, and I'm very happy to be here with you. Some of you very well know that Bahadur finds excellent titles for the talks and for meetings. So when he sent me his title, Troubleshooting Understanding Radiation Oncologist, as being a radiation oncologist, I got a selective perspectivity and I got shooting as irradiating instead of troubleshooting, problem solving. But when I prepared my presentation and sent him, he told me that leave it like that. So I will tell as it is. Can I take my question, Ata? This is a question just for radiation oncologists, but I will be very happy if surgeons, oncologic surgeons can answer the question. It's about fractionation, but in multidisciplinary teams, you know, you are aware about our schedules. After skin sparing or nuclear areola sparing mastectomy, which fractionation schedule do you prefer for chest wall irradiation? First one is 26 gray in 5 fractions. The second is 40 gray in 15 fractions. Third one is 42 gray in 16 fractions. And conventional fractionation, 50 gray in 25 and 50.4 in 28 fractionation. And no idea which one you prefer. Please submit. It is very technical, I know. Yeah, I see. Majority says that conventional fractionation. Okay.
Okay, we may close.
Thank you very much for submitting your answers. Now, okay. This is the content of my presentation. Here, I'll focus on chest wall radiotherapy and reconstruction. During the discussion part, Hassan prepared a case about breast conserving surgery, reconstruction, and irradiation. So we will touch that issue during the discussion parts, during the case discussion parts. First, I'll talk about post-mastectomy radiotherapy, who are the candidates and which volumes are our target, but I won't bore you. It will be a very brief talk for the first part. In the second part, I'll talk about nipple-sparing mastectomy and skin-sparing mastectomy, because we used to do that just simple mastectomy or just modified radical mastectomy, but the change is turned to nipple-sparing and skin-sparing mastectomy. So the technique is quite different than before. This technique affects radiation oncologist indication. It is very important because among radiation oncologist colleagues, we discuss this issue very much all over the world. And I have some messages that I want to deliver to oncoplastic surgeons and also breast surgeons regarding this issue. And finally, I'll do a brief overview on proofs for reconstruction and radiation. You all know that, so it will be a very short overview. And finally, I'll talk about the technique, and I promise I won't bore you. Technique will be very short as well. So let's come to post-mastectomy radiotherapy. If you do upfront surgery, lymph node positive patients mostly receive radiotherapy. There is a debate about if the lymph node is 1, 2, 3 positive, but we irradiate some of them, not irradiate. But I want you to know that we mostly irradiate them according to results of early breast cancer trials meta-analysis, because lymph node positive patients had benefits regarding the benefit of radiotherapy regarding local control and overall survival. But when it comes to lymph node negative patients, T1 and T2, radiotherapy does not have any benefits regarding local control and overall survival. So if these patients undergo mastectomy with T1 or T2 tumor, we don't deliver radiotherapy, no indication. Regarding T3 tumors, it has impact. Finally, two studies published 3 years ago show that none of T3 tumors has benefit on regarding local control and overall survival as well. We were irradiating these patients just because of local control, but these studies show that radiotherapy has impact on overall survival, not only on local control. So let's come to neoadjuvant systemic treatment. T4 and N2, all these patients undergo neoadjuvant systemic treatment and surgery, and we irradiate these patients comprehensively. For T1 to T3 and N1 patients, these patients also undergo neoadjuvant systemic treatment, particularly considering the biology, but majority are going other than luminal A tumors. When we come to radiotherapy, there are two ongoing trials for this group of patients. In NSABP and RTOG trial, if the lymph node positive patient converts to lymph node negativity after sentinel lymph node biopsy, you may not give any radiotherapy. In one arm, they are not giving any radiotherapy, and in the other arm, they are giving radiotherapy to chest wall and lymphatics, but in one arm, patients are not receiving radiotherapy. For now, we don't know the results yet, but in future, maybe, and all patients will not receive chest wall and lymphatic irradiation. But for today, radiotherapy decision is based on pre-chemo stage for now. And in current practice, we are irradiating the chest wall. In other words, we are irradiating your reconstructed breast. The other parts, I mean, the lymphatics irradiation, the selection of the volumes depends on the state of art of radiation oncologists. We are using many factors such as sentinel lymph node biopsy, axillary dissection, number of positive lymph nodes, biology, tumor size, and location. But we irradiate the chest wall because majority of the local recurrences are seen on the chest wall. Why I am stressing this issue? Sometimes surgeons are sending their patients to me. I mean, these are not the surgeons that I'm strongly collaborating with, but they say that the patient has axillary lymph node metastasis, and I did a very good reconstruction. Do not destroy my reconstruction, just irradiate the lymphatics. This is impossible. If you send the patient for radiotherapy, we irradiate chest wall, so your reconstructed breast is on the target. And I'm passing to second part. What about nipple sparing and skin sparing mastectomy? Does your technique affect radiotherapy decision? As I said at the beginning of my talk, T1, T2 patients, if they do not have any axillary metastasis, and if you do a simple mastectomy, sentinel lymph node biopsy, or mid-phase radical mastectomy, no need for post-mastectomy radiotherapy. If you do nipple sparing or skin sparing mastectomy, do the patients need post-mastectomy radiotherapy? There is no prospective randomized trial at all, so we cannot say totally that it is a safe procedure. There are some retrospective trials, many retrospective trials, testing if nipple-sparing mastectomy or skin-sparing mastectomy is safe. When we look at the results with median follow-up 5 years, after nipple-sparing mastectomy, it seems very safe. Local recurrence is 3.5%, and after skin-sparing mastectomy, it is 3%, and the recurrence at the nipple areola complex is really low, less than 3%. But the reality is, some of these patients received radiotherapy. So the local control rates are due to surgery or the addition of radiotherapy. We don't know yet. So as radiation oncologists, we still do not find these techniques very convenient. And when we look at the DCIS patients, if DCIS patients undergo modified radical mastectomy, or not modified radical mastectomy, but let's say that simple mastectomy and sentinel lymph node biopsy, the local recurrence is less than 4%, almost zero, as we know that. But in typical study, it has been shown that local recurrence rate is up to 16%, so very high for a DCIS patient. And if the anterior margin is 1 to 2 millimeters, and if the DCI is more than 5 centimeters, then the local recurrence rate comes up to 16%, really, really high. So let's again turn to invasive cancers. If you leave a skin flap more than 5 millimeters, there is a 60% of breast tissue and 9.5% of breast disease. Why is it important? You leave the subcutaneous lymphatics here. It is a subclinical disease here. So we feel that we have to irradiate here. And we do not want thick skin flaps. And if the tumor is located in the upper inner quadrant or axillary tail, you should be more careful, because when you're doing this technique, you leave more tissue in upper inner quadrant and axillary tail. So among my colleagues from all over the world, we discussed this issue, and different societies published some recommendations and their practices, and one of them is South American practices. They also say that if the skin flap is more than 5 millimeters, they send the patient to radiotherapy. And here, if the patient has triple negative biology, also we irradiate the patient even she is T1 and T2, undergoes skin sparing or nipple sparing mastectomy, because when triple negative tumors are very immunogenic, and when you irradiate them, some part of the lymphatics are also in the field. So with some immunogenic mechanisms, you also increase the overall survival. So I certainly believe that triple negative tumors should receive radiotherapy after skin sparing or nipple areola sparing radiotherapy. And I'm not talking about T3 tumors, because at the beginning of my presentation, I said that even modified radical mastectomy, they benefit from irradiation. Positive notes, they should receive. And I don't want to talk about positive surgical margins, but closed surgical margin is very important, because positive surgical margin is unacceptable. So what I do in my current practice, for T1 and T2 patients, after skin sparing or nipple sparing mastectomy, if skin flap is more than 5 millimeters, I irradiate these patients. I do not send breast MRI to all patients after mastectomy, because I'm working with some groups and I know how do they their surgery. For instance, I work with Cem Yılmaz, and I know that he does excellent surgery. I irradiate his patients with locally advanced or lymph node positive. And planning CTs, I see that there is no skin flap. But if the patient is coming from another surgeon, then I send the patient to breast MRI, and I discuss this issue with my radiologist friends, and they send the patient to breast MRI to measure the skin thickness after 6 weeks. And 6 weeks is not a huge time for the delay of radiotherapy. And I measure the skin flap. If it is more than 5 millimeters, then I irradiate. If anterior margin is 1 millimeter or less than 1 millimeter, then I irradiate, and I irradiate a triple negative biology for lymph node negative patients. For DCIS, it is very clear if the tumor is more than 5 centimeters and if the anterior margin is less than 2 millimeters, then I do postoperative irradiation. Now, these are my messages to breast and oncoplastic surgeons. In my center, breast surgeon does the surgery, then the oncoplastic surgeon comes afterwards to do the oncoplastic part. So this is the first message is for breast surgeons. If you are doing skin sparing mastectomy or nipple sparing mastectomy, the technique by itself might be an indication for post-mastectomy radiotherapy. In case of simple mastectomy, these patients would not receive radiotherapy. So don't say to your patient that I'm doing mastectomy, but it will be a skin sparing, and you will not receive radiotherapy. Just leave the door open. The tumor may be very close to anterior part, you know that, but the surgical margin might be very close, and you can leave a thick skin flap. So we don't know, and if it is triple negative, and this time also you warn your patient. And if you are an oncoplastic surgeon, don't push breast surgeon to leave a thick flap for an optimal cosmetic outcome, because in daily practice, I know this, the oncoplastic surgeons push our breast surgeons just leave a thick flap. Just this thick flap may be an indication for radiotherapy. And in case of radiotherapy decision, be aware that reconstructed breast is always irradiated. Don't say just irradiate the lymph nodes and leave my reconstruction. Now I'm going to second two parts. All these basic proofs. Autologous reconstruction is more compatible with radiotherapy from MRO study. We know that if you do an autologous reconstruction failure rate is only 1%, but you do implant, it is 18%. This is one of the basic facts. And radiotherapy complications are quite different from implant reconstruction and autologous reconstruction. In autologous, we see fat necrosis and flap shrinkage due to fibrosis, but it is not as high as implant reconstruction. In implant reconstruction, capsule contracture rates might come up to 60%. Infection, because we prepare an environment for infection, and repeated infections can cause capsule implant loss. Pain, skin necrosis, and we might have implant loss up to 20%. And you can do either two-stage implant with expander or just directly implant. If you do a direct implant, capsule contracture rate is high. But if you do two-stage implant and if you irradiate the expander, then this time implant loss is high compared with implant irradiation. The most important issue is radiation-induced fibrosis. How we do this? With radiation, we increase myofibroblast production, and this myofibroblast production causes the capsule contracture. Where it happens in front of the implant and back of the implant and fascia of the pectoralis major and minor muscle. But here we should remember that radiation-induced fibrosis depends on genetic and epigenetic factors. Let's imagine that there are two patients and I do the treatment planning, the same homogeneous dose distribution. One patient develops radiation-induced fibrosis and capsule contracture, the other does not. This is all genetic and epigenetic factors. But on the other hand, there are some other factors, recurrent infections, recurrent surgery, connective tissue disease are also factors for capsule contracture. And radiation-induced fibrosis starts within months and increases by years, and majority is seen in first year. I don't know you like ADM, you use it or not because it is expensive, but I should remind you that ADM is compatible with radiotherapy. And this is my final comment about this issue, this facts. Prepectoral implant is better for capsule contracture. It has been shown by Senatürk 2 years ago, and these delineations are from my kitchen, from my treatment planning. So the patient came to us, this is the implant, and this is our subclinical target volume, the clinical subclinical disease, and these are our clinical target volume, where implant is not our target, it is not important, it is just a mass. But the flap just front of the implant and also behind the implant is our target, and we define these volumes and we give it to physicists and they irradiate it. So this is, let me show you, this is a patient with subpectoral implant localization. Purple one is the implant, the red one is our clinical target volume. In other words, here we irradiate, here light pink one is pectoralis major and blue one is the pectoralis minor muscle. When we irradiate, if capsule contracture happens on the fascia, then it pushes the implant. I'm sorry, It seems I'm very excited, and it pushes the implant and destroys the cosmetic outcome. This is another patient. It is a partial subpectoral reconstructed breast. Here with blue, you see that it is the pectoralis major, minor, and this is the clinical target volume. So if the patient develops a capsule contracture on the fascia of the pectoral muscles, it pushes it. You can also jeopardize the cosmetic outcome, but not as much as this one. And this is the patient with prepectoral localization, and here the muscles, you irradiate clinical target volume. On the fascia, capsule contracture may happen, but it is under the implant, so it does not push. So that is the result of Syncode's publication. And I wanted to show with delineations from my treatment planning system. So how do we irradiate? How do we shoot? In other words, so today we are using advanced technologies. Shooting is not a trouble at all. But 15 years ago, when I started implant irradiation, we were sending the patients to deflation. So majority of my colleagues, oncoplastic surgeons, were using two-stage implants. They were using expanders, and I was sending the patient for deflation because we were not able to have an optimal internal mammary chain coverage. But now today, for the last, let's say that 7 or 8 years, I'm not sending patient for deflation. No deflation is needed. We are using different techniques, field-in-field IMRT, IMRT volumetric art, or hybrid technique. So optimal coverage is obtained without increasing organs at risk. No problem at all regarding the part of radiation oncologists. But in order to reduce capsule contracture, our European colleagues published some guidelines, delineation guidelines, and it's called ESRO guidelines. So what do they recommend? Here, this is a patient with subpectoral implant. Here is the flap, and they delineate this part. And if the patient has a higher stage, also the behind of the implant is also in the target volume. So this is the risky area, and we have to irradiate this part. And this is another patient. If the implant is located as a prepectoral, then they recommend to irradiate the flap and also the pectoral, the front of the pectoral fascia, because we think that this is a risk area, just put the implant on it. And they recommend to irradiate this part as well. So as a result, with following their recommendations, in our clinic, we made a study. Yes, really, you decrease the pectoralis minor and major doses if for subpectoral located implants. And with this technique, we use BMAT. But when you use BMAT, it is impossible to reduce cardiac doses as much as you do classic field-in-field IMRT. So for me as an oncologist, sparing the heart is much more important than sparing the pectoralis minor and pectoralis major muscles, because cardiac toxicity might be a problem than the cosmetic outcome. And another option, another debate for this issue is, with ESRO recommendations, you cannot make an homogeneous coverage in the chest wall. In your clinical target volume, yes, you can do a homogeneous dose distribution, but in the chest wall, let's say that some parts will receive radiotherapy and some parts will not receive radiotherapy. Some parts doses will be high and less, and you cannot completely save the front of implant and part of the implant because these are riskier areas. So I am a bit hesitative. We save the implant, homogeneous dose distribution in CTV, but not in the chest wall. Will it be a good cosmetic outcome? I don't think so, but we will see in future. But we can do we can play with fractionation. We can use conventional fractionation, hypofractionation. When I started irradiating implants, I was doing not only even not 2 gray per fraction, I was using 1.8 to preserve late effects. But when hypofractionation came to our lives, we were more tend to hypofraction, and then we look at the outcome of hypofractionation from the radiobiological point of view. Hypofractionation is absolutely more safe for fibrosis because we reduce the total doses. So these are very technical. I'm very radiobiological. It's for my radiation oncologist friends. But this alpha beta ratio 3 and 2 gray gives an idea about the fibrosis. And if you do hypofractionation, it is less than conventional fractionation. And also in hypofractionation trials, when we look START B and Ontario trial, in START B trial, breast shrinkage is less than conventional fractionation, which means that capsule retraction and radiation-induced fibrosis is less with hypofractionation, and also excellent and good cosmetic result rates does not differ in Ontario trial, but less with for hypofractionation. This trial comes from Milan group. They did 15 fraction in 40 gray to implants with lymphatics and chest wall irradiation. And when we look at the results, fibrosis rates are really low. The median follow-up is short, but we know that majority of the radiation indeed fibrosis is seen in the first year. And a few months ago, 1 week fast trial came, so we will be able to finish radiotherapy in a week. But when we look at the patients who underwent 1 week irradiation with immediate reconstruction, the numbers are very low, 7 or 11 or 8. So for now, it is a bit early. And this is my final slide and my final comments to surgeon. Radiotherapy shooting is not a trouble at all, particularly for local control. And do your optimal surgery. Do not use expanders if radiation oncologist needs a deflation or not. It is not a problem for us at all. Capsule contractors and implant dose are important factors that we concern as radiation oncologists. Don't forget genetic and epigenetic factors play a role, so say this to your patient. Reduce recurrent unnecessary surgery. As radiation oncologists, we prefer partial subpectoral or prepectoral implants localization. Regarding estro and acrop guidelines, we will see the outcome, but I'm not very much fond of them. But hypofractionate, moderate schedule seems better now. And I hope to see most of you next week in our 4th Breast Cancer Virtual Conference, Breast Istanbul. Thank you very much.
Thank you so much, Professor Beşe. Well, we're just a little bit behind of our time, but Hedges, there are 2 questions, which is a hot topic. I think that we must ask to Professor Beşe before going on to the tumor board. Do you let me ask these 2 questions to Professor Beşe, Hedges?
Yes.
Okay.
Okay.
Yeah. Professor Beşe, there's a a bunch of questions which just concentrate on one issue. That's the controversial issue about radiating after skin sparing mastectomy. And let me see, because I just got all those questions together. Dr. Zahid is asking, what is the idea behind giving radiotherapy for skin flap over 5 millimeters thickness? And then Elaine is also asking from UK, and she is saying that some patients have subcutaneous fat larger than 5 millimeters. So I'm also interested to know the evidence behind this, because Tamer is also saying that from United Arab Emirates, there is no thick flap and thin flap. There is a plane we follow. It is different in different patients, but we really do not control its thickness. And Konstantin from UK again says that the surgeon should follow the plane of dissection, which defines the thickness of the flap based on the patient's anatomy. So we should not correct suboptimal surgery with the radiation treatment. What do you say about this? Your proposition about radiating the flaps?
Yeah, very good. I'd like to answer the question. So, very good questions. First of all, there is no prospective randomized trial, so we cannot say that it is safe. And what we are concerned that subcutaneous lymphatics, and these are risky volumes. There's a subclinical disease there. That's why, as radiation oncologists, we concerned. And if you leave a thick flap, then the amount of subcutaneous lymphatics increases. I don't know if you can manage thick flap or thin flap. I have no idea, but I treat the patients coming from different surgeons, and I see that when I do planning CT, in some patients there is no breast tissue, with a very good cosmetic outcome and no skin flap, but some of them it is like breast conserving surgery. There is a huge flap, and when I sent the pictures of just planning CTs to my radiologist, they say that yes, there is this breast tissue, not only the fat tissue. So as a radiation oncologist, I cannot be convenient. That's the result that I irradiate if the skin flap is more than 5 millimeters. And this is not my only idea. The Canadian Society, South American Society, also European Society proposed to irradiate if the skin flap is more than 5 millimeters. So I'm not the only one on the target. All radiation oncologists think like this.
Okay, thank you. So one final question from Andriy from Ukraine, a friend of us as well. A question to you again, Professor Beshe. What is your approach to adjuvant radiotherapy after partial LECAP flap breast reconstruction? Do you do boost to the tumor bed with flap?
Well, that is a very important issue. I think we will discuss that issue during the discussion part. But right. Do you want me to leave to the discussion part or answer right now?
Well, maybe Andrew would leave earlier. Maybe it's good to answer now briefly, then you can go deep into that discussion during the tumor board.
It became a problem for us right now because to say the truth, the benefit of boost is only 3%. But we deliver boost if the patient is younger than 50 years old age, if the patient is grade 3, if the patient has grade 3 tumor, and if the patient has extensive intraductal component. For patients, I look at the other factors, and if there is a flap and the surgeon says that I removed a huge part, and if it is difficult for me to localize the boost region, then I skip giving a boost, but I'm not very convenient, very happy at all. If the patient is at a young age, let's say that 40 grade 3 tumor and with an extensive ductal component, then I should deliver boost. There is no evidence behind this. And for these patients, I recommend surgeons do your surgery, put the clips, and try not to change as much as possible the original site, or help the radiation oncologist for the better cosmetic outcome. And oncological safety comes first for these group of patients. Is it clear or not?
Yeah, thank you. I hope that it is clear for Andriy as well. So as I told you, we're a little bit behind our schedule. So I would like to give microphone to Hassan to present his cases. And I'm just really collecting your questions now. I can see read and see on the chat box. So I will let Hassan to ask these questions to Professor Beshe during the discussion period. Okay, Hassan, the microphone is yours.
Thank you very much, Dr. Güloğlu, Dr. Avneli, for this very nice and excellent organization. This is another part of our meeting, and we do this type of tumor board meeting all the time in our profession practice. Basically, challenging and interesting cases are presented and ask opinions what to do, but I want to underline it is important to understand that medicine, and especially oncoplastic surgery, is an art, not just a science. And today we have a very experienced and distinguished oncoplastic surgeons and radiation oncologists. I want to start with our first case. 43 years old premenopausal woman. Her body mass index 24, no family history, no smoking history. And she came to us with left breast mass. And in her physical examination, we found mass in left upper inner quadrant and no any extra lymph node involvement. And in her radiological examination, we found a lot of multiple lesions in left breast, inner quadrants, and suspicious lymph node in axilla. You cannot see very well, but multiple foci located in inner quadrants, especially not just one tumor, multiple tumors in inner quadrants, you can see. And core biopsy from the index tumor, from the biggest tumor, is performed, and final aspiration biopsy was performed from suspicious lymph nodes. And in MRI, you can see multiple foci here in inner quadrants. The biggest one, 2 centimeters. And through-cut biopsy revealed invasive ductal carcinoma, and axillary final aspiration biopsy, we didn't find any malignant cells. And Ata, can we ask our first question to audience? We have a question for you. I perform breast conserving surgery, including oncoplastic approach in multicentric tumors. Yes, no, abstain, and no idea. Please, can you answer? Yes, we can receive the results. Okay, almost 50% of our colleagues, they don't perform breast conserving surgery in multicentric tumors. And I want to share the patient's pictures. Tumors are located here. And now I want to ask to Dr. Mauricio, what you wanna perform to this lady? 43 years old, left breast cancer, multicentric cancer, and axilla is negative. What you recommend to this lady, Mauricio?
Yeah, I think we have a lot of options, including studying her desire, including the preparation of the surgeon. Nowadays, I always prefer to make a conservative surgery when I'm treating breast cancer. Of course, if I can and if she wants. I probably will choose in these options the number 3, but I'd like to see better the case, to examine her breasts and talk with her, of course.
Okay, thank you very much. She has a lot of small foci also. We can see under ultrasound, but they are not palpable. Which method you prefer to excise all of them if you will perform breast conserving surgery? And I will ask to our audiences also this question, but in your practice, which way you prefer?
I normally use technetium, but sometimes we can have some of our guys that don't have nuclear medicine to work together, then must use another kind of location. I don't like to use wire localization in fat breasts because it moves, it's changeable in the place. Then we can use, in Brazil, carbon, activated carbon, or ink we can use to using ultrasound.
Okay. Thank you very much. Atta, can we ask to our audiences our next question, our second question? Yes, my colleagues, we wonder your approach for non-palpable tumors, which way you prefer, wire guidance, role, intraoperative ultrasound, marking of skin projection, stain or no idea. Can we take the results? Yes, a lot of colleagues also, they use intraoperative ultrasound role, but mostly they prefer wire guidance. What we perform, use in our daily practice hook wire usually, sometimes roll. But thank you so much because you underlined for other localizations methods like carbon or other methods. And after hook wire with lymphoscintigraphy also, we perform sentinel lymph node biopsy and left upper inner and lower inner quadrantectomies with sentinel lymph node biopsy and reconstruction with inferior pedicle breast reduction. And the pathology results, multiple foci, grade 2 tumor, ER/PR positive, Ki67 50%, and axilla was negative. And these are preoperative images and postoperative images. And patients, if these patients came to us like this, and this is a real one, and we performed, I will ask what you prefer, but I want to ask to Regis. Regis, if the patient came to us similarly, multicentric tumors, but the breast shape and breast size is not like the previous one, what do you want to do to this patient?
Dr. Hassan, congratulations for the case. Can I have the age of the patient? How old is she?
45. This lady is 40, young patient, 45. And no comorbidity and no another like important situation to underline and to say.
There was an important question raised in the chat about the genetic testing for young ladies. Maybe I would first ask a genetic test. It usually takes 2 weeks or maximum 3 weeks to get the results. I think we could wait for the result. If she has a BRCA1 or BRCA2 mutation or a TP53 mutation, maybe we would change our advice. But if she hasn't any history family or any mutation, it would be
no any family history.
Yeah, it would be possible to perform an oncoplastic surgery, but in this case, she doesn't have many ptosis, very limited sagging, and it's difficult to do a mammoplasty. It's possible, a mammoplasty like a Lejour. Modified Lejour, we can do it, but the breast will be very small. In very small breasts, I usually use a replacement technique. In this case, it would be possible to do a rotation of the breast, including the thoracolumbar flap or even the thoracoepigastric flap. Maybe some kind of volume replacement. There is since some months ago we started to have available, the intraoperative radiotherapy, intrabeam. It's very interesting in this case if the lady wants to have a breast augmentation. It has less capsular contracture. It would not be suitable for this lady because she is very young and multicentric. It's not the case. But in some cases where the patient has small breasts and she fits the inclusion criteria for this kind of technique, it would be also a good technique.
Okay, thank you very much. What about Cicero? Are you agree with Regis, or do you have another recommendation for this lady? Can you perform oncoplastic breast conserving surgeries to this patient, or Hassan, it is not good candidate and breast size is important, let's perform nipple sparing mastectomy, it is better for this lady? Can you say something like this?
Yes, but analyzing the picture, I think that it is a fatty breast, no, not so ptotic breast, medium size, and a multicentric tumor. It's not a good relation between the size of the breast and the position and size of the tumors. Tumors are in the medial part. Just analyzing the picture, I would do a nipple sparing mastectomy by the inframammary crease, put an implant in pre-pack, and do the symmetrization with the other breast with an implant. But just analyzing the picture. This is a suggestion, of course, because most of times we try to do a breast conserving surgery, but I don't know if in this patient it will be possible.
Okay.
At least me.
Okay, thank you so much. And another pictures of this lady. And what we performed oncoplastic breast conserving surgery, but results was like this. I want to ask again to Cicero. Cicero, I think this result is maybe acceptable, but it is not excellent. And this lady was unhappy in the end of this surgery because she wanna put her bikini. And could you prefer with this operation to put like breast conserving surgery, but to put especially for this type of small breast, implant insertion under the muscle or under the glandular tissue immediately? Is it possible? Or I can perform this surgery like this. If she wanna augmentation, we can perform after radiotherapy. Or do you take into consideration her wishes, this type of wishes?
I'm a professor of bioethics, so the desire of the patient, we should understand the desire of the patient, but autonomy is not something that 100% we should agree and do what the patient wants. I don't think that putting an implant in this case, we will have a good outcome after radiotherapy. We have good outcomes after radiotherapy in patients that already had an implant. So we don't have too much extrusion. We don't have too much capsular contracture when we do breast conserving treatment in patients that already have an implant. But sometimes in this kind of patient, for example, when you put an implant here, patient will have capsular contracture and discomfort with her breast. I think that if you wanted before a big breast, then it was better to go to a mastectomy and nipple sparing mastectomy and implant. But if she accepts the fact that her breast will be not so big, best option is the option that you choose, to do a breast conserving treatment, to do with oncoplastic technique, to do a symmetry, and she can go with her bikini, not a problem, if she don't want to have a big breast.
Thank you. Dr. Beşir, what do you think if we insert implant, if we perform bilateral augmentation mammoplasty to this lady, what about your radiotherapy? It will be more difficult, or like a lot of complications, or more complications, like we should wait more complications, or for you it is not important, I can irradiate augmented breast, or like this breast, no problem for me. Can you say something about this case?
I completely agree with Cicero. We irradiate implantations just for augmentation, and we don't face lots of problems. It's completely different than the implants of after mastectomy. So if you put an implant just for augmentation, it's not a problem at all. Because capsule contractor rates are quite low in in these patients. Actually, I say that I have never seen a capsule contractor after the irrigation of an implanted breast for augmentation.
But maybe Mauricio, if we will use augmentation with oncoplastic breast conserving surgery, which plan you prefer, like under muscle or prepec you prefer?
I definitely disagree in the first use to be put under the muscle. We have a patient that has glandular tissue. Then, for me, for a while, for this moment, at the first time, I would prefer subglandular location. If tomorrow we have any complication with contracture, with infection, we have another option that comes submuscular. Now, if we use the submuscular plan, we will lose the second one. And then if she has a complication at the submuscle plan, we won't find another plan like over the muscle, because the muscle will be atrophic and we lose the second plan. It's difficult for me right now to say it will be a wrong way to put submuscular, but for me it's very, very, very difficult to accept today to use this plan.
Okay, thank you. We have a lot of cases. I want to continue our any questions from audiences, or I couldn't see, but I think no any questions. Okay. I continue for second case, 65 years old lady, postmenopausal, no family history, and she has comorbidity. Her platelet level 100,000, problems with hepatic insufficiency. And she came to us with left breast mass, and in her mass we found mass in right breast, and in another, in left breast, and palpable lymph node in left armpit. Her breast was like this. And in her mammogram, we found bilateral masses in upper quadrants, her ultrasound, and suspicious lymph nodes in her left armpit. Core biopsy, invasive ductal carcinoma from right and from left sided. And in her PET CT we saw. And I want to ask to Dr. Cem. Cem, 65 years old lady, bilateral breast cancer, unifocal, just in left side, like around the index tumor, some ductal carcinoma in situ we can see in her mammogram, but she has some problems with platelet level. What you recommend to us?
Well, one of the main problems is her hepatic insufficiency. Does she have cirrhosis, child A, B, or C? And I would love to discuss this issue with the anesthesiologist also, because the anesthesiologist will guide me through her surgery. So that the first thing that I would love to talk to my anesthesiologist. The biggest problem is not the platelet level, because it's 100,000. It's enough for enhancing the hemostasis, and the coagulopathy is not a coagulopathy in the level, but the biggest problem is the hepatic insufficiency. So I would love to discuss the duration of the operation with my anesthesiologist. So
for this side, no any problem. We talked with our anesthesiologist, and she said everything is okay. Her liver enzymes, they are normal, and no any problem for general anesthesia.
Then no problem. The oncoplastic surgery is a better option for that. Oncoplastic surgeon, the surgery is the placental node biopsy. It's a good option for this patient.
Okay. And we perform bilateral quadrantectomy and right sentinel lymph node biopsy and left axillary, limited axillary lymph node dissection and reconstruction with breast reduction and postoperative results. And in pathology results, tumor size 50 millimeter in right side, grade 1, no lymph node involvement, and in left side, 28 millimeter, grade 2, and with limited axillary dissection, 1 of 6 lymph node was positive. And I wanna ask, we have a question. Atta, can we ask our fourth question first? Then I wanna discuss with my colleagues also this case. And we performed axillary intervention. My question is, incision for tumor excision and axillary intervention should be with same incision, different incision, abstain, and no idea. And I wonder the approach of my colleagues. If the tumor is located outer quadrants, which type of approach you prefer?
Regarding to axillary incision and comparing to the
yes,
oncoplasty
and axillary incision should be same if it is possible, or every time should be different. I make axillary incision differently.
It is more dependent of the size of the breast and the technique that you use to reconstruct. For example, if you use inferior pedicle in a big breast, it's much better to do the incision by the same oncoplasty incision, the same access. If you have, for example, a round block, it's better to go for separate incisions. So I think that my decision is more related to the position of the incisions in the breast and the distance between the incision and the axilla than having a general rule.
Yeah.
For example, in ferropedical big breast, most of times I use the same incision.
Yeah, I'd like to, reinforce this opinion of Dr. Urban. I think in most of the case it's possible to do the same, to do a same incision. It's more usual, but it's not something we have to be obstinate about it, because maybe it may lead to complications if it's too difficult, if you have to undermine too big part of the breast or compromise the vascularization. You have to individualize. I was one of the 2% that answered abstain, because it depends pretty much on the case.
Okay. Thank you.
So you were the single abstention.
Yeah.
Sorry?
Regis was the single abstention in this answer.
Okay, and I want to ask you, Dr. Beşer, we have one of, from before Dr. Beşer, I want to ask you, Dr. Cem, then I will go to Dr. Beşer. Cem, we found one lymph node positive. Do you perform axillary lymph node dissection to this lady?
It's a luminal A tumor with grade 2, and it has a good prognosis. So I would love to talk with Professor Nuran Beşer about irradiation, not performing the axillary dissection. I wouldn't do axillary dissection.
Okay, Dr. Beşer, what you recommend to us?
No, I will definitely recommend not to do axillary dissection to this patient. It is okay. I mean, 6 is enough, more than enough. And this is a breast conserving surgery, and she deserves radiotherapy. And I will only include the level 1 and level 2 because luminal A, I will not go further at URTC trial. So I won't propose axillary dissection.
Same question for triple negative tumors. If she has triple negative tumors, what about your approach? Do you change your mind or?
Again, no. Again, no. No, I wouldn't change my mind. And if the tumor was that had a high Ki-67 level, I wouldn't do it again, because she's going to receive the adjuvant treatment, the chemotherapy plus the irradiation.
Dr. Beşer, are you agree with Dr. Cem?
Yes, usually triple negative tumors do not do axillary metastasis, but if it is like so, irradiation is much more important than surgery for triple negative tumors because it's an immunologic tumors, as I believe. So I won't propose axillary dissection, but if it is 1 to 6, I mean, if 6 lymph nodes are removed or 5 lymph nodes removed. If it's a triple negative tumor and if you only remove 2 lymph nodes and 1 lymph node positive, then I will force you to go axillary dissection according to MI20 study. Because majority of the recurrences are on the axilla and they propose extended radiotherapy for triple negative subtype.
Okay, thank you so much. Before our next slide, I want to ask to our colleagues another question. Atay, can you ask to my colleagues our next question?
Fifth one?
Fifth one, yes, please. And these patients, we perform inferior pedicule breast reduction. But my question is, if patient has comorbidity or like smoking history, my pedicule should be, for reduction, my pedicule should be inferior pedicule, superior pedicule, abstain, no idea. Independent from tumor localization. Of course, we choose our pedicule according to tumor localization, but without taking into consideration what is your preference? If the patient has comorbidity. Yes. Almost half of my colleagues choose inferior pedicule and half of them superior pedicule. And I wonder, Dr. Regis, for example, for symmetrization or for your daily practice, do you have, of course, depends on patients, but what you want to share with us?
Yes. In oncoplastic surgery, the most useful pedicle is the inferior pedicle because the tumor is often in the upper quadrants, and so it's easier to keep the vascularization of the areola by the inferior pedicle. But I myself prefer to use a superior pedicle for most of the patients whenever possible because I believe it has a better cosmesis. In this case of comorbidities, the superior pedicle must be more risky. And instead of using the inferior pedicle, if there were another option, I would choose another option. It would be the superomedial pedicle. Dr. Jen must seen many of these in Düsseldorf because they use it very often. It's very useful. You have the opportunity to take off tumors from the inferior quadrants and also to the upper quadrants, and it's very reliable because 60% of the vascularization of the breast comes from the perforance of the internal mammary vessels, and so I think it's a good option. Would be my option in this case.
Mauricio, what about you? In a risky patients like smoking, if patient has smoking history or some comorbidities, which pedicle you prefer?
I think just like Regis. If I care with the tumor, and most of them are superior, inferior is the best one. If I care with statics, the supermedial is the best one. I don't like, Hassan, I don't like patients with comorbidities, especially smoker. Smoker is hair problem. Necrosis, infection, open wound is our problem. And not this patient, because she has a very big and fatty breasts. Then Dr. Beshi will kick me if I send her a breast like that, too big for her work and to perform radiotherapy in this patient. But what I think about, not this case, but a smaller breast, a breast that I can perform oncoplastic surgery, or I can perform just a lumpectomy. In these patients, I don't perform oncoplastic techniques, and I prefer to solve, to treat her, letting the aesthetic improvement for a second level of importance. I have history with patients that complicated, smokers especially, and I don't like to move tissues, to make big incisions, to make big scars in these kind of patients, because they lose very often a big amount of tissues.
Okay, patient selection is very important. Yes, thank you very much. And similar, another patient, 59 years old lady, left breast cancer, upper outer quadrant, T2 N1, and she has smoking history. Similar patients, invasive lobular carcinoma, she received neoadjuvant chemotherapy, and after neoadjuvant chemotherapy, we have very good response. Cicero, this lady, we performed inferior pedicle breast reduction to previous patient. Similar breast, but she has smoking history. And we use neoadjuvant chemotherapy to this lady. Do you perform inferior pedicle breast reduction to this lady, or what you recommend? Or for example, free areola, or are you afraid if you perform?
No. This case is perfect to send to a friend. No, I would do in this case inferior pedicle, even if the patient is a smoker, because of course we know that smokers have 8 times more complications and bad aesthetic outcomes. But she's 59 years old, or no? Yes.
59. Yeah.
Yeah. So maybe a fatty breast. Of course, she has some risks. We can go to inferior pedicle if the tumor needs, or we can be more conservative and do just a periolar incision if the patient don't want to. But we should think that after conservative treatment and neoadjuvant chemotherapy, she will go to radiotherapy. And if we have a smaller breast, maybe it's better in terms of fibrosis and to radiotherapy plan. I would do a classical oncoplastic ferropedical in this case.
Let's see what we performed. We performed free areola grafting to this lady. We are not so courage like you. We were afraid and directly free areola reconstructing as you saw. My question again to you, Cicero, when you perform free areola grafting, like
when
you perform inferior pedicle or like pedicle breast reduction, and when you prefer to perform free areola grafting.
In my practice, I think that
my red border, I don't perform pedicle breast reduction, something like this. Can you, like, you have a big experience, all of you, you have a very big experience, and I want to take some tips and tricks about this subjects.
Well, inferior pedicle is the safer technique that we have to save the nipple and areola complex. If you go straight ahead in the technique, it's very, very difficult to lose completely, for example, nipple and areola complex. It's not the same as when we do, for example, superior pedicle. Superior pedicle is easier as a technique, but has more risks to lose the nipple and areola complex, for example. So for big breasts, I try to avoid the graft. I try to free graft. I just using very, very, very big breasts. This in my practice, most of times I can solve with inferior pedicle. And again, inferior pedicle is more difficult to do because it's more demanding as a training and to have skills to do. But if you go straight ahead in the technique, it's very difficult to lose the nipple and areola complex. It's not the same as an superior pedicle, but inferior pedicle, I will be safe. It's my opinion.
Hassan,
yes.
Can I add? You asked us tricks. Can you put the anterior where I can see the patient in front of you? Yeah, this one. We have some tricks. When you see her, I definitely would prefer to, in this case, perform a free areola. No, I probably use inferior pedicle. Some tricks. If the size of the neck complex right now in my future is more than 8 to 9 centimeters, be careful. But the inferior pedicle still is the safest one. The first trick, you can perform one under correction because she's 69 years old, yeah?
59.
59, okay. Probably she doesn't want to come to Brazil to go to beaches using the bikini, only the bottom part. She doesn't want to go to beach to topless. Then under correction is one trick. Gigantomasty, when the neck complex, the actual, is at level of umbilical scar, free graft. And another very, very important, as high I need to put the neck complex, as wide I need to perform the pedicle. Sometimes we use all the inferior tissues, like a wide triangle, not inferior pedicle like a tube, but like a triangle wide, as wider, as high I need to go. I think these are 3 tricks important too, especially for less experienced surgeons.
Regis, do you, what about your approach about free areola?
Yes, I use free areola grafting in very rare cases. The last two cases, one was a reduction of 6 kilos, 6 and 300 kilos from one side and 6 kilos from the other side, and the other was 4 kilos from one side and 4 and something from the other side. And so it's very big breasts. In this case, it's perfectly possible to do the inferior pedicle and also the supermedial pedicle. There was a comparison between supermedial pedicle and inferior pedicle. It was a publication, I don't remember, I have to check it out, but it was more than 10 years ago. But it was a large prospective series comparing supermedial and inferior medial pedicles. And it was bothly effective in very big breasts. And the rates of complication were the same. The supermedial pedicle is so reliable than the inferior pedicle in terms of vascularization. In this case, probably I will do the inferior pedicle because of the tumor. The tumor is in the upper quadrant. Maybe it would be easier to perform the quadrantectomy, but I think both are possible.
Okay, Dr. Cem, do you agree with our colleagues or?
Well, it depends on the blood
Yes.
yeah, it depends on the blood supply and the tumor location. But I generally try to, there are 3 different blood supplies in the breast, so I generally try to preserve the more than one. So to resect one region and to preserve one, preserve at least 2. So I totally agree. I totally agree.
Okay. And in her pathology results, we found pathologically complete response. In axilla also pathologically complete response. Dr. Nuran, you irradiate lymphatic region.
For now, we are irradiating and we are waiting the results of 2 randomized trials. But for now, she deserves the breast and the comprehensive lymph node irradiation. No problem at all. And with these breasts, it is very easy for me to do the planning.
I would have a question for Dr. Beza.
Sure.
That lady would be suitable for radiotherapy without a reduction. The size of the breast will be it's too large.
There will be lots of complications. It will be very difficult for us and for her. Lots of side effects. So I appreciate if you do the reconstruction and make it smaller.
Okay, thank you.
I will ask your approach and I will complete because we completed our time, I think. This is left locally advanced breast cancer after neoadjuvant chemotherapy. As you saw, and nipple areola complex also invaded with tumor. And we performed bilateral skin sparing mastectomy, right skin reducing nipple areola sparing mastectomy, and to this side, skin sparing mastectomy and reconstruction with areola and reconstruction of the nipple. I want to ask to Cicero. Cicero, do you perform or what do you think about nipple areola reconstruction immediately? Or we should let it to reconstruct nipple areola reconstruction later?
I do it later most of times. What I am afraid with the grafts is if you, for example, do a mastectomy, put an implant, and it is very frequent that you have, for example, some inflammation in the notches, and sometimes you can have epidermolysis and dehiscence of the graft, and then it can compromise the implant. I tend to do it in the second time. We use the micropigmentation in 3D micropigmentation sometimes and do together with the nipple reconstruction, the results are good. I mean, you have a very nice result in this case, but I'm afraid from the problems that we can have in the graft that can compromise something more important, which is the reconstruction, I think.
Regis, what about you? Do you perform with, like, when you perform nipple area sparing, not nipple area sparing, skin sparing mastectomy, do you perform areolar reconstruction or nipple reconstruction immediately, or let it perform later?
When I do breast conserving treatment, usually I try to reconstruct the nipple complex at the same time because it's easy to know the right position. But when we do a mastectomy, it's more difficult. The implant can change over time. It can rise. It can change. And if you put the areola in the wrong place, it will be a problem in the future to correct it. And maybe in this case, I would prefer to do it delayed.
Mauricio, in this type of patients, do you use directly implant or like you use expander and then changing with implant, or directly you use implant? What is your practice?
Hassan, let me understand. On the right side, you performed skin reducing mastectomy. That's it? No, then I prefer.
Reducing nipple areola sparing mastectomy to the right side, and to the left side, skin sparing mastectomy. But we removed nipple areola complex and bilateral reconstruction with prosthesis.
Okay, perfect. The right side, I definitely don't use implant. I use expander. I think it's safer, it's easier, but especially because it's safer. On the left side, normally implant. Just completing the previous questions, I normally, when I am afraid about the position, about the supply, blood supply, I normally use just the papilla when the other side is a donor papilla. When it's not donor papilla, I forget and I prefer to make the neck complex later.
Okay. Jem, do you perform immediately or let it later? Open the Ata. Can we open the microphone of Jem?
Now it's open. We always delay the procedure because as we do it immediately, the location of the nipple complex is 99% wrong. So we always prefer delayed.
Okay. Thank you very much, my dear friends, dear colleagues, and to all participants also. Thank you so much. I wanna, we have over the time, and I wanna let the microphone, Dr. Bahadır and Dr. Regis. Thank you very much. You stayed until now with us. See you in our next meeting.
Okay, thank you very much, Hassan, and our friends in the panel. Yes, we're very behind of our schedule, but there are 2-3 questions, which are very beautiful questions. I would like to ask these questions very quickly, and I would like to hear your answers because we don't want any question to be unanswered. There were many comments on your discussion. I'm just skipping them because they're really valuable comments, and you can read it on the text because audience is reading all the chat and the comments on the chat box, but you were so busy to discuss the issue, so you would not follow them, but you can read it now. So I would like to just ask 2 questions, which is about the discussion during the tumor board, and both questions came from Konstantin. And first he asked, would you excise the footprint of the tumor or the area seen on her final imaging after neoadjuvant chemotherapy, the area around the clip used for localization? Who would like to answer this question? Very quick answer. If all of you are, agree on one answer, one of you can just give this question's answer.
When you have a breast and you do oncoplastic surgery, most of times you can do it naturally, doing your oncoplastic surgery. It is not necessary to remove all the zone of the previous tumor.
Mm-hmm.
Very short.
Okay. All right. Okay. Thank you. that was very short and good. So another question from Konstantin. Wouldn't it be a risk to perform a free nipple graft to a patient who will receive radiation treatment to that area? So, well,
Hassan,
it's
your time, Hassan.
Hassan can answer this, or any one of you.
About free nipple, I don't have good experiences. Like whenever I put free nipple, I lost it. For this reason, I prepare nipple reconstruction, not nipple grafting. But areola grafting works wonderful. And if the patient is risky, like smoking or jugulum nipple distance more than 35 or 40 centimeter, I don't take any risk, and I perform free areola, and I let nipple reconstruction for later usually.
Okay. Any more comments for Hassan's answer? No. Okay. I'll go back to questions for Professor Bechet. As the first question comes from Bruno Carelli. Dr. Carelli asks, when we use prepectoral reconstruction, the flap is bigger than 5 millimeters. In this case, the radiotherapy is always necessary?
No, there is a misunderstanding actually regarding the flap thickness. I do not send all patients to breast MRI and see the thickness. But if I'm not sure about the surgeon that I said, so I don't want to say that all patients we are sending to radiology and seeing the flap thickness. So if I hesitate, then this time I'm doing, but regularly I do not do that issue. This is the first remark that I want to say. And the second question is, if you put it prepectoral and the flap thickness is more than 5 millimeters, then I want to know if there is a rest of breast or not, because when you put it prepectoral and there is a breast tissue more than 5 millimeters, then I find it risky. I think that there would be some clinical disease.
Okay, thank you. Okay. Another question for you, Professor Bechet, this time from Dr. Paulina Lugo from Ecuador. What do you think the use of full expander prior to radiation treatment to avoid encapsulation?
Well, it's a very good question. Some people recommend this. The reason is when you do the full inflation, then you decrease the vascularization and during radiotherapy. So this skin dose receive less doses. But in implant after mastectomy, the skin is always the target. So I do not propose this. For encapsulation, that's okay, a good result, but for the oncologic outcome, I do not recommend.
And again, another question, I mean, this is a common question. You know, you offered a radiation treatment after skin sparing mastectomy, whether with the nipple areolar complex sparing or not, but should it be different if the patient had a node-negative disease? Would you again recommend a radiation treatment to the patient with, negative axilla, although the skin flap is something like 5 millimeters or 6 millimeters? Do you think that it is thick?
I mean, it is not a must. We don't know yet. It's just a proposition. It is not a must. Let's think that the patient is 60 years old, luminal A tumor, and the flap is 6 millimeters. No need for that. But in my daily practice, I see reconstructions like breast conserving surgery. That's why I'm afraid. So this is not a must, just a proposition. Just a proposal.
Yeah, I know that is a controversial issue. That's why you receive many questions from your to your presentation. All right, one final comment, and I would like to hear your opinion on this. This is well, from the beginning of the meeting, I received 2 or 3 questions from Professor Ostapenko from Lithuania. What about MRI, use of MRI when, you know, planning the surgery? And also, what about genetic testing in these especially young patients? Well, you can answer this by one by one. For example, MRI question can be answered by Hedges, and one of you would answer the question for about genetic testing.
Yes, about MRI, I'm not a big defender of it. It's a very controversial topic. I know, for example, that Cicero always does it, and it depends on anyone. But my point of view is it's very useful for some cases where there is doubt, where the breasts are dense, where the patients are young, where the risks of genetic alterations or family history is high. But in general, I don't use MRI for everyone, because if you compare, even in the old series of breast conserving therapy, where there were only poor mammograms and poor ultrasound and anything else, and you compare radical mastectomy and breast conserving treatment, the local recurrence is the same, and the results are good, the survival is the same, and I think in some cases it may be useful, but I don't think we have to generalize. And MRI has also some problems. There are a lot of false positives. The patients have to do extra biopsies, many times guided by resonance. That is difficult. In my city they don't have it. They have to move to another city next to Goiânia, and so it's not so easy to do this. But it's my opinion. I know that it's a very controversial topic.
Okay. What about genetic testing then, especially in the young patients? What is your experience on that? How is your clinical practice about this? Cicero, would you like to answer, or Mauricio?
You want that fight with Regis here?
I perform genetic testing, especially younger than 50, and if she has a family history. Okay. I love for me the best panel is we have family history, they're alive, and she has breast cancer and she's a young owner. I start asking tests for the families, like for her sister, for her mother. And if positive, I ask if she wants to do, because genetics testing can be a good light, but can be a big problem.
Okay, thank you. All right, thank you very much, everyone. It's a long and tiring session, a meeting which just lasted nearly 3.5 hours. But it was very useful. I learned many things from all of you, each one of you, and I hope that everyone who just attended this meeting from the beginning or from the middle, I hope they also enjoyed this meeting. We were so much pleased to host you all here for the 3.5 hours, and we look forward to meet again in near time. So we may maybe make some live surgery, sessions together. That would be more attractive for everyone. So we can just keep us, just gather us as like a club, So I know that we're a little bit far away to each other, but with this COVID-19 thing, we get used to do this kind of Zoom meetings together. So now the club is getting larger, and we hope that the next meetings we will get together. If you would like to say a few words, Hedges, on your side, please.
Yes, it was a very nice meeting. It was a pleasure and honor to be with you. We respect pretty much the Senatürk. We know your work. It's a very serious one, and it was an excellent time together. I'm sure that there will be other projects for the future, and I invite you to register also to the www.oncoplasticacademy.com for also some activities. We're planning in the future also to do some more live broadcasting and maybe online courses and other activities. And if you are interested in oncoplastic surgery, I would like you to be also in Senatürk. I saw that you asked for everybody to let the email. But if you could also, if you're interested, you could also let it in the Oncoplastic Academy website. It was really a nice time together. Thank you very much, Bahadir, Hassan, Beshe, Jem, and our colleagues from our friends from Oncoplastic Academy, Dr. Cicero, Dr. Mauricio. Wonderful. Thank you.
Okay, thank you very much again. All of your questions and your attendance. See you in our next meeting sometime in very near future. Bye-bye.
Bye-bye.
Thank you. Bye-bye. Bye-bye.